So this is the 2022 Spring OBGYN coding presentation. And just one more time, you can kind of figure out, hopefully we're down here at Peace for Moms at the halfway point. So let's go ahead and start with some performance measures. You know, when I think about payment for performance, one of the things that always comes up is your QPP. And sometimes on these calls, I get somebody who's a first-time person hearing me talk, and you know, usually around like this last year, I had at least a dozen calls from people who said, you know, this company says that they can help me with my QPP scores, and it's like $5,000. What do you think? Should I really do it? And I'll talk to you about how you can know whether or not you have to do it. One of the things here is when we look at the performance years, right, we can kind of see how the system works about 2 years behind, right? So what you reported in 2017 is 2019, and in this year we're getting paid based on what we did in 2020. Now this negative 9% impacts Medicare, and you're going to get that 9% cut forever if and you don't score well enough on your quality measures. Now some of you are in an ACO. Some of you might be in a clinically integrated network. Some of you might be part of an IPA. But, you know, if you're not, then you need to know a little bit more about the QPP program, and I'm going to help you out today. So if you take a look at this grid, there are 4 things that are measured: cost, quality, improvement activities, and promoting interoperability. So there's 4 things that get measured. The one that you really can't control that much is cost. But these other ones, you know, you can control. So your quality measures here, your promoting interoperability is your EMR, and your improvement activities are, you know, for most people, you know, you do a patient satisfaction survey, and then you're going to go on the Medicare website and attest that you did your improvement activity. Your quality is usually pulled out of your EMR, right, by your vendor and submitted at the end of the year. And then promoting interoperability is something that you still have to do on your own. The agency down here in the bottom has finalized that you've got to get 75 points from here this year in order to exclude yourself from those penalties, that 9% penalty. And this isn't always very easy. And I will warn you that there might be stuff I talk about today that doesn't impact you, and that's just good. You still get your 3 CEUs, but there are some people on here who maybe they took a job at a practice because the previous office manager left or was fired, and you show up on day one and you're like, oh my gosh, you haven't done QPP in how many years? And then you start looking at your remits and you see this 9% reduction in revenue, and you don't know why. And here's why. Here's what you do. So this is CMS, QPP.gov, QPP.cms.gov. And, you know, it's going to pop up here, these little drop-down boxes. And under MIPS, which is the Merit-Based Incentive Program, the first thing you should do is just check participation status, right? Because a lot of OBGYNs don't see a ton of Medicare patients. So I'm going to start with this because normally what happens when these doctors call me, they think that for some reason they have to do it. But if you go to that next screen, it's going to say enter the NPI number of the person that you want to know if you have to report. That's called the QPP participation status. And you just say, I want to check all years, right? And what'll come up here is, this is one of the physicians I work with. It'll come down here and it'll say that she's associated with one practice. She's a NP in an OBGYN practice. And MIPS eligibility, individual, no. So she does not have to even report her QPP measures. And this practice has 3 nurse practitioners and a PA, and none of them meet the criteria. You know, they're not seeing enough Medicare patients or whatever. Do they even have to participate? So this is step number 1, you know. Don't freak out until you go to this site and take a look if, you know, you even have to participate. Now, this next one is alternative payment methods, and this is if you're in an ACO. You don't have to worry about this because your ACO or clinically integrated network is probably helping you out with this. The best thing to do too is if you really want to get an idea of what you need to do, you can call them. The QPP organization that CMS contracts with is like the easiest phone call you'll ever make. So if you're in a small, underserved or rural practice, you just pick your state. I think we're in Georgia. I was in Charleston doing this talk yesterday. You just call them. If you got a pen, you write down that number. And I'm going to tell you, as a consulting nerd, I still call this number probably 10 times a year because I always have a question because I don't want the practices that I represent to get that penalty. So if I have a question, I call them. They log the call, and then they'll return your response to you so you can have it on record. And I've never had a problem getting through to these folks or anything. No, Nicole's sending me a message. I think I just called it Peace for Moms. I put the one in there that you sent me. So it is the right one. I just didn't see a title on it. So sorry. Next thing we're going to talk about are some CPT changes. There were about 405 changes to the code set in 2022, 249 new codes, 93 revisions, and 63 deletions. Now, here's something cool if you're a coding nerd like me. You can always bring this up at your next AAPC chapter meeting. You know exactly how many CPT codes there are. It keeps growing. It was like 7,000. When I got involved in it. Now there's over 73,000 ICD-10 codes. So the first one is kind of simple. It was just a change to the integumentary. 11981 is a code. Insertion of a non-biodegradable drug delivery implant, bioresorbable, biodegradable, or non-biodegradable. Now, there's a new parenthesis note underneath that I'm sure none of you need to know about, but for the removal of a biodegradable or bioresorbable implant, they want you to report the unlisted code 17999. So if you're doing non-biodegradable drug delivery implants, which I think, a lot of folks are, and you remove the bioresorbable or the biodegradable, use the 17999. So you can go to your CPT book, check that out, ask the nurse practitioner or the PA, if you're using biodegradable or bioresorbable. So I guess because you typically don't remove these, you use the 17999. If you're using non-biodegradable, the removal code is still the same. But I would check that one out. There's only a few things you have to really check out this year. Again, some GYNs do repair. OBs do repair. It's not real common, but, I had to come up with something to show the folks back in December, and this is just one of them. What they basically did is if you open up to the repair section in your CPT book, they've rewritten the entire section, making it a little bit easier. But it basically addresses wound closure using suture staples or tissue adhesions, either singly or in combination, chemical cauterization, electrocauterization, wound closures, and it strips as the primary repair material. This little sentence here, just the reason I'm showing it to you is because I get questions about this all the time. Like, what if I use a strip? Can I still code that as a simple repair? And the answer is no. That's all bundled into your E&M code. I get another question. I had this question in Memphis last month. I was doing a talk, and OBGYN, they were getting all kinds of denials for their lidocaine injections to do procedures. And I was like, well, yeah, there's one lidocaine code in the HCPCS book, but that's for like a heart attack. And by the way, local anesthesia is included in the surgical code and not separately billable. So believe it or not, there are people who still, haven't figured out because, maybe they were my story is simple. I was the check-in girl at the ophthalmology department at Indiana University while I was going to college. And one morning I came in and the checkout girl had died. So I got promoted to the checkout girl, and I knew nothing of billing and coding, but Arletta had all these notes. And that's normally how people progress in the coding and billing world, because as an outpatient coder, you can take your CPC, your CEMC, your CRC, your CPMA, you can take all these classes, but you don't really learn that much. And we don't have to go to college to become an outpatient coder. You do have to have a little bit more specialized training if you're going to work in a hospital, like an RHIA or a CCS. We just don't get that benefit. Those are people who started out and wanted to go in coding. A lot of coders, wanted to be astronauts, and the checkout girl dies, and all of a sudden you're the checkout girl, and later on you become the manager. And so that's kind of how it works. So sometimes people don't get this training. In the reproductive area, they basically just deleted one code: surgical treatment of an ectopic pregnancy requiring total hysterectomy. So what the AMA does is they monitor the number of times these codes are used, and if a code's not used, they just delete it. Sometimes they'll revise it to kind of make up for recent technologies, but most of the time they'll just delete these codes that aren't used. With ICD-10, most of you should know these changes, but there's a new code, F32A, for unspecified depression. I just want to show you that one. It's always really important, though, from a risk adjustment standpoint, that you try to make your doctors use something like F32O to F32.5. These codes do not have a risk adjustment value. So if you're in a risk adjustment contract with Blue Cross, United Healthcare, Cigna, or you're part of an accountable care organization, or you're part of a clinically integrated network, they're probably telling you to avoid these codes. And it's not just because they're unspecified, because there are unspecified codes like heart failure unspecified, COPD is an unspecified code, J44.9. Again, heart failure is I50.9. There are unspecified codes that pay, but these two, you might get reimbursed for them, but in the long run, it affects your risk adjustment score on that patient. So again, just remember, try to use F32.0 to F32.5. That new code just made it easier for you to not get credit for anything. This information is from the errata for ICD-10. I always download a free ICD-10 book every year. ICD-10 CM is just clinical modification. That's how you know that we've customized it in America. But the World Health Organization publishes the ICD-10 code for every industrialized nation in the world. And then every country gets a copy of the ICD-10, makes the adjustments for America, and then in America, we just put the CM on it. But it comes from the World Health Organization to the CDC to the, oh my gosh, can I not remember the name of it? If you just Google WHO, CDC, ICD-10, and look around a little bit, you'll find your entire ICD-10, the guidelines, and everything online, and that would save you buying an ICD-10 book every year. Cool. When I send the link to OBGYN Society, I'll include the link to that free ICD-10 book. Okay. I don't buy books anymore. I just, I download this. I get the CPT book from the AMA, and it's on a Kindle, and it works really well for me. Heck, half the time we just Google stuff anyway. There's some new back pain codes, that came out. This errata tells me no change to that code. We deleted these introduction verbiages, what other things that doctors can document to support that code. And then you'll see over here what they've added, right? So you'll no longer be able to use M45 because it's going to require now a fifth character. And that's what these fifth characters are. So make sure you just check those out. Everybody's got low back pain. Cough changed, believe it or not. So they've added some cough codes. The RO5 is a 3-character code. Now it's a 4-character code. And you can take a look at these. My company is probably best known worldwide. I'll say in America. We sell nebulizers, and it's nebdoc.com. And when these codes changed, this is the number one reason that physicians order nebulizer treatments. So when the code changed and they started getting denials, they called me. And of course, I said, well, these aren't medically necessary covered ICD-10 codes for a nebulizer. But if that's all you get, you just have to, copy this page and send it to anybody who requests something for a cough. Don't forget, too, as a coder, you're going to see all these little notes. Code first, excludes 1, excludes 2, use additional code. That's kind of where the ICD-10 book or the ICD-10 PDF download really can help. Because I get a lot of calls from people who go, why is my cough syncope being denied? And I'm like, are you using R55 as your primary code? And if they say no, this is just an example, I'm like, well, that won't work. I don't know if anybody has used this yet, but there's a non-suicidal self-harm code available. So non-suicidal self-harm, it's just another code. I guess, if you have cutters, that's non-suicidal, but they might also have a laceration. So when it says code also, that means that code for the injury will be second. So they expect to see this non-suicidal self-harm code along with something about like a superficial laceration. So, you might see some young people. There's a lot of young people who are depressed right now, smoking doobies. Just hate that word, but it's so funny to say. But there's a lot of cannabis abuse right now. And, when I do my risk adjustment talks, that's one of the number one thing that we undercode at most of the ACOs and CINs that I work with compared to the national average is cannabis dependency. And it's rampant. When I audit hospital notes now, there's a condition where if you smoke too much marijuana, you usually go to the emergency room because you have uncontrolled nausea and vomiting. So I say that jokingly, but, there is a lot of depression in our society and a lot of cannabis abuse. Social determinants of health are so important, and I'll talk a little bit about them later on. But I would encourage everybody on this call to take your pen and write down Z55 to Z65. These are codes that will help you support your level 4 visits a little bit better because we have a new option to document and code for social determinants of health. Now, the good thing about this is the doctor doesn't necessarily have to be the one who puts that in the assessment and plan. So there's only about 5 times there's about 5 services that can be done by a nurse or a staff member as long as it's in the note. So, for example, the EMR is going to tell us the BMI. So we can use the BMI without the doctor calculating it. The class of a wound, if you have an ulcer, that can be determined by a nurse or somebody other than the physician, NP or PA. And then you have the social determinants of health. So as long as it makes it into the record, we can code for it. And I'll show you more about that today. But these are some new codes. Sometimes people struggle because they lack a high school diploma and they don't have a GED. These are moderate complexity problems. Sometimes people are sick because of their physical environment, inadequate drinking or water supply. Homelessness is big, right? So they've added a fifth character to homelessness. And so you might be treating people who are in a shelter and maybe they can't get the kind of care that they need. So you might order enough data, and if you document this, or if you have a moderate presenting problem, you can use that with that code to help again support your level 4 visits. And we're going to come back to that today. Here's some more new codes. It's sad, but when I look at these codes, I see myself as a child. I'm like, That was me. That happened with me. We had housing instability, because my dad left us, and we were constantly, going around. Hi, Erica. Food insecurity is huge. We talk about food deserts now. Hell, we're talking about baby formula on the news right now, and how, my kids are 35 and 25, so I don't get impacted. But my wife and I had to go to Target last night to pick up some tie-dye materials for her kindergarten class. And just out of curiosity, we walked over to the baby. And you all know this because you're women, I guess. We went over there and there was nothing. So then I went to the front desk and I said, yeah, do you have the formula behind the desk? She said, no, we don't have any. So that's food insecurity. If you don't live within 2 miles of a place that has food, that's a food desert. I think it's 2 miles. But some places in the, in the city, it's really hard to get food. If you go out into the rural areas, if there's some places in Albany that I work at, and the only grocery store within 2 miles is like a gas station thing. So housing instability, other problems related to housing and economics. So people are in foreclosure. And you don't have to ask these problems. Normally people will tell you, but that's kind of how the social determinants of health work, and we'll come back to those. As far as well visits, some of you, again, are PCPs for your GYN patient. There is a litany of preventative medicine codes that we can bill. I'm just going to touch on a couple of them, a few of them, maybe 5, and tell you what people don't document that hurts them. So if you're a group that's doing annual well visits, GO438 and GO439, you might want to listen in. And again, if you don't and you're a CPC, then this will just help you with your 3 hours of CEUs. If you go to the Medicare Claims Processing Manual, which you can get to if you go to cms.gov, you scroll down a little bit and you're going to see the 5 most common reasons people visit this site. And in there, it's going to be manuals. Click on the manuals, and it's going to take you to the Medicare Claims Processing Manual, which is 100-04. And when you click on that, you'll see all of these chapters. And Chapter 18 covers all your preventative. So if you ever had a question about what Medicare covers, Erica left, about these screening services, you can just go there. CMS.gov, manuals, and then you go to 100-04. Chapter 12 is really cool too, because Chapter 12 is all the rules for billing physician services, shared visits, prolonged services, prolonged E&M. It's just a really great resource. So when people ask me, how do you know so much? I'm like, because there's only really 2 chapters I have to go to, 18 and 12. The big thing that's changed with the annual well visit is now CMS is expecting us to ask questions about opioids. So, there are some seniors who take opioids that are prescribed to them. And I've just incorporated this into our EMR. They want to know if the patient takes an opioid, and if yes, right, we have to discuss the benefits from other non-opioid pain therapies instead. And then we have to discuss risk factors for opioid use disorder. So whoever does your annual well visit, whether it's an LPN, an RN, an MD, a PA, or an NP, or a CNM, we just want to make sure that we're capturing this opioid question. And that's going to impact your Welcome to Medicare visits, which is GO402, and both your annual well visits. So here's the GO402. If you're doing a Welcome to Medicare because you're a primary care GYN, the simplest thing you can do if you have your pen is just write down ABC of IPPE on Google. And it'll download these grids that tell you everything you need to know. So you go to Google and you just type in, or Bing, or DuckDuckGo. I'm trying to be more woke in the world. I just use Google. I don't know why. My wife probably has a reason why I shouldn't use Google, because she has reasons to boycott everything. But we've been married for 32 years, so if she tells me to delete Netflix, I delete Netflix. I've accumulated enough that giving up half of it to her in a divorce is just too costly. This list tells me everything I need to do. The number one thing that's missing here is the visual acuity. Let me see if I can find that real quick. Yeah. So under examination, they expect a visual acuity. And you don't have to have an ophthalmology setup. You can use a card. It doesn't matter, but you have to document that that little burger. And a lot of people that I audit don't do that. And if this ever gets audited, they can take the money back for that. This is also kind of curious. If you think about this end-of-life planning, if you remember when McCain and Palin were running for office, they talked about death panels and stuff, and they kind of misunderstood the whole definition behind that. But it's basically end-of-life planning. You know, do you have an advanced care? Do you have a living will? And, you know, we can bill for this during an annual well visit and use a modifier 33, which I'll talk about, and not get billed. So here, you're not required really to do anything, but we just need to talk about that. And a lot of times that's missing from an IPPE. And the other thing that's missing from the IPPE is, why does Medicare want you to do this code? It's for someone who is 65 years or age, and it's their first year of Medicare eligibility. And before anybody chimes in, there are a number of people who have a disability and who get Medicare that you might see. So they might have a young person who has Medicare, regardless of their age. The first year that they get their Medicare card, we can do this visit. Medicare wants us to do this visit because they want to make sure that patients understand, you know, all the free things. So it's kind of like, hey, welcome to Medicare. You live to be 65, and here's all your freebies. So typically, you know, you just download this and you can put it on your website, or you can print it off and just give the patient. But that's the reason for this visit, is welcome to Medicare. Here's a bunch of freebies. And all these freebies are also in that chapter 18. The only thing that's not really billable with the Welcome to Medicare is the depression screen. The depression screen is included. It's bundled into the GO402. So Z13.31. I'll go over that in a minute. There you go. So GO444 is just a simple PHQ2 or PHQ9 for Medicare. It's a 96127, 96127 for everybody else. With Medicare, you can bill this every year, usually after 11 months has passed. The problem with this code is, if you do a PHQ2 on a patient who has a PCP, you're going to get denied, because you only get one per patient per year. And if the PCP knows how to code correctly, they will be the one who already bills that. But again, just for the limited number of you who do both, and again, in Memphis, I had at their OB meeting, I had 30% of the practitioners there worked in rural Tennessee, and they were the PCP, the OB, and the GYN for the folks in their city. So because some of you might be that, I want to just go over these optional codes for you. Now, the Welcome to Medicare is still going to require the opioid questions. Here's what most people miss: the health risk assessment. You have to have a questionnaire that usually mine has about 45 questions on it. And you have to do that every year to bill these codes, and you have to keep a copy of it in your records. You can do it, the patient can do it, the MA can do it, but the Medicare reimbursement rates for these are so significant because they expect you to spend about 20 minutes doing the health risk assessment. Somebody has to do it. Then you're going to see ABC of AWV is another file. That's just what this is. And it talks about the health risk assessment has to be there. You have to have a list of current providers and suppliers. So, you know, if they are on a nebulizer, if they're on breathing treatment, and most people just put their pharmacy there as well. Medical family history, potential risk factors, including current and past. This is, you know, you can use any appropriate screening source for depression, which may be selected from, your PHQ2 or your PH9. The number one thing that's missing in these notes after the HRA is functional ability and level of safety. So you really want to see if the patient has any hearing impairments, falls risks, and you have to document your hearing. You don't have to have an audiometer to do that. You can do it by observation and just make a statement that, hearing, from direct optical observation, there was no clinical hearing deficits in this patient. But that's usually missing. The HRA is usually missing. And then this is missing. The established written screening plan of care for the next 5 to 10 years. With the IPPE, you had to tell them in your document all the things that they're eligible for, and documenting your note, you gave them a copy of that. For the annual well visit, you have to literally make a plan and say, okay, you need a COVID shot, your pneumonia shot, your mammogram, your colonoscopy. You make a list, and you have to document in your record that you gave them the list, and that puts the onus on them to make the appointment. You don't have to have a referral department, but you do have to inform the patient of what they need to have done. This is the number one reason that they pay you $150 for this code. But again, the patient only gets one of these a year, and if they have a PCP, their PCP has probably already done it. But if you're the PCP, you can do it. So here we still go with the referrals in your HRA. It should say things about, do you have fall prevention? Are you getting proper food? Do you get proper physical activity? Do you smoke? And do you need to lose weight? Which are all things that are covered under the Medicare program. Okay, that's the point behind the HRA. The only thing you can't bill with the GO438 again is the depression screen, because it's included in that code. So once a month I get a phone call from somebody who says, why am I getting denied on my depression screen? Well, usually you're using the wrong diagnosis code, or you're billing them with the code that already includes the depression screen. Normally it's just the wrong diagnosis code. Now, the subsequent annual well visit, you don't have to do as much. You still have to do the HRA, and here it says you can update the HRA. It should take no more than 20 minutes. So it's not 5 questions. And I have, providers who send me, is this HRA okay? Is it okay? And it has like 5 questions on it. And I'm like, no, that's not okay. Let me send you mine. And because they're normally clients of mine, or they were 5 years ago, but they're paying me for an audit now. And that's a deficiency that I put in their audit. And I normally will send them sample HRA forms, samples of my annual well visit templates, my IPP templates, and then they can just kind of incorporate that into the EMR. You can also just call your vendor and ask them, if you're part of a large hospital group, hopefully somebody there already has developed the AWV. If I were you, though, remember, there are good coders and bad coders, and I will tell you that there are fewer good coders than bad coders. So I have looked at these forms before in the EMR, and they're just insignificant. They don't count. Now, for this code, the follow-up one, you're not required to do the hearing test. You do have to get their weight, blood pressure, and anything else you feel is appropriate. You'll calculate out their BMI. Detective of any cognitive impairment by observation. So you should have a heading that says cognitive impairment, no cognitive function reduction noticed in patient via direct observation. Again, the screening forms, you have to give them something about the next 5 to 10 years of care. And that's it. So, and then any referrals. Again, these are nutrition, physical activity, not so much unless they get a referral to get PT, OT. Tobacco use you can do in your office. And weight loss, if you're a provider and you schedule an appointment to discuss their weight loss because they're a diabetic, providers should just bill E&M codes based on total daytime. So, if you bring a patient in for a separate visit and they meet with the CNM, the NP, the PA, or the MDDO, and it's just a counseling type of encounter. Just bill on total daytime and use the primary diagnosis as what you're counseling them about. Good deal. Well, that was painless. Now, again, if you're doing the annual well visit, it's also very important to remember the 99497. And 99497 is advanced care planning. There's a slide in here that just talks about that code. It pays the equivalency of a 99213. Again, everything I'm talking about right now is Medicare. It doesn't include Medicaid. Medicaid's pretty cut and dry. Getting paid is a different thing. But we shouldn't complain here in Georgia because some places that I work have 7 or 8 Medicaid carriers that all have, they try to have different rules, but they're still supposed to follow the state's rules. The big thing with the 99497, there's 2 things. You have to document that you spent more than 16 minutes because it's a 30-minute code. So this is one of those codes where you can go 1 minute past the midpoint. I mean, infusions are like that, even critical care. Critical care is the first hour, but if you go 31 minutes, 30 minutes in the AMA book, but I always preach to go 1 minute past the midpoint. You don't have to spend a full hour with a patient to go critical care. Same thing with therapeutic infusions, chemotherapy. All those time codes in those sections will allow you to go to 1 minute past the midpoint. Hell, physical therapy and occupational therapy are billed in 15-minute increments, and all you have to do is 8. That's why they call it the 8-minute rule in physical therapy. So there are some codes that allow you to do that. The other key thing is if you're an OBGYN and you do have a patient who has like ovarian cancer, cervical cancer, you can bill this code. The patient would only be responsible for the co-insurance or deductible if you billed it. There's no limits on how often you can bill it. But if you do it during your annual well, just put a 33 modifier on it and it'll cover it 100%. So a lot of times doctors are saying, hey, well, what can I do for this patient? A couple things that you could also think about is if you're a physician, you can include this in your total time, but that might be a mistake because, this code is going to pay $84 on its own. And if the medical problem is enough that you have to spend, enough time just starting your E&M, you look at your E&M and it's 30 to 39 minutes, 30 to 39. That could be your total daytime for your 214. And then you could add the 99497 to that, and you'd end up doing about $200. Or you can just take that time, add it to your E&M time, and maybe do a 215, which is still going to pay you around $200. So this code traditionally is done with an annual well visit by your LPN or your RN. They do the counseling, and then they get to bill that because, nurse practice, scratch that, LPNs and RNs can't bill E&M codes based on time. So that's kind of a little insider scoop depending on who does your annual well visits. So if it's a provider, I would just add together the total time for the visit, bill the 215, unless you feel like you've only spent this much minute on the E&M. And if you wanted to add a 99497 to the 214, you could do that, but just remember that the patient's going to get a bill for that if it's not done at the time of the annual well visit. 33 is just preventative. Don't panic. I mean, most of us would only use this on the advanced care planning code. Here's again some more information on that depression screen. It's up to 15 minutes. A lot of people think you have to go a full 15 minutes. CMS doesn't even tell you what form to use. Again, most people use it. I like the PHQ-9. Again, it's GO444 for Medicare, 96127 for most other insurances. And there's your diagnosis code, screening for depression. I don't recommend billing this for somebody who already has depression. I'm bipolar, and I have bipolar depression. I'm totally under control with medications. That's okay. But every time I go to my psychiatrist, I fill out a PHQ-9 form. But because I have depression, they're just using that as a screening tool, and they don't bill Blue Cross Blue Shield for it because I already have a diagnosis of depression. They would use 96127 anyway. Okay? Alcohol screening is not a good code to use anymore. This is being audited. This code requires that the patient fail their alcohol screening. They fail it. And then you have to go the full 15 minutes of counseling. So if you're one of those groups that does annual well visits and you do a depression screen, kind of avoid this one unless you can still have them do a form. But if they don't fail the form, then you can't bill for this because there's no medical necessity on why you would do the 15 minutes of counseling. Tobacco counseling is a great code for anybody who smokes in your Medicare world. These codes are greater than 3 minutes. When doctors call me and tell me that, well, I used to do this all the time, but patients started getting a bill, I'm like, well, that's because you didn't use the right diagnosis code. F17210 is the proper diagnosis code for that. The other thing is you have to say greater than 3 minutes. I prefer that you just write the exact minutes that you spent with them. And you should have a statement underneath it that says, you know, I spent 4 minutes in tobacco counseling cessation. We talked about over-the-counter medications. We talked about prescription drugs. And I provided the patient with the 1-800-STOP-GEORGIA-SMOKING number line. You have to put a 25 on your office visit. This code is really cool because CMS allows you to do it 8 times per year per patient. So you get 2 attempts to help them quit smoking. Each attempt includes 4 visits. So if you want to build that, it's a great code to build in addition to your E&M service. Most of you do the pelvic and breast exams on your CMS patients. You know, we know the diagnosis codes. You can do this every 2 years unless the person's at high risk for cervical cancer. I'm not a doctor. I don't know what that is, but some doctors will tell me, oh, yeah, I know what that is. And I'm like, cool. If you want to build this every year, it's Z77.9. Also, I don't have the discussion about your beliefs in pelvic and breast exams because some doctors say, well, why would I do that on somebody who's 65 or older? And I'm like, I don't know. That's what the code's there for. So you could build this on your disabled patients who are younger who have, Medicare. Here's what's wrong with that code. The biggest thing is ACOG has put out a list of 11 elements that make up a full GYN exam. You have to get 7 of those. So a lot of times when I audit OBGYNs, they just have a statement that says normal, and you can't do that. So you have to really itemize it. This is based on the 1997 changes in documentation, and it is expected that you would elaborate on at least 7 of these. There is no special code for breast exams. If a patient has had a mastectomy and you don't want to do a rectal, you still have 9 things to choose from, right? Let's pick 7. Make a template and go with it. But just don't say pelvic exam was normal. That doesn't count. That GO101 allows about $30. This Q0091, obtaining a pap smear, again, every other year for free for the patient, or every year if they're at high risk for cervical cancer. This also pays about $30, and there's no documentation requirements for that other than you mentioned in the note that I've obtained a pap smear. And a lot of times I don't see that order on the documentation for the Q0091, and I just tell the doctor, if you're going to obtain a pap smear, just write that down on your note. And these are both billable with a medically necessary E&M code, so you can do a 213, a GO101, a Q0091. Same thing with the annual wells or the IPPEs. So you could do a GO439. You could do a 99213 if they have a medical condition. You can build the 99497 with a 33 modifier for prevention. You can do the depression screen, the GO442. You can talk about counseling for tobacco during that visit. You can do intense behavioral therapy to avoid cardiovascular disease, like for your hypertension. That's a 15-minute code, but you can put out the little food chart, and have a plate. I have a plate from my diabetic coach, and it says, this is what you put in this section. This is what you put in this section. And I'm like, is there a cake section? that's on my plate, and she laughs and says no. So there's a plate. The doctors that I work with who do this just go over the food pyramid. I saw a funny meme years ago that said, "Isn't it funny how the food pyramid looks like a piece of pizza?" And that's not on the food pyramid. Shared visit changes. Okay, so this is critical. Only have to chime in if you wanted to. You only have to listen to this section if you have a MD who sees patients on the same day as the nurse practitioner, the PA, or the certified nurse midwife. So if you're in one of those small areas, you might be consulted in the emergency room for a GYN problem, and you decide to admit the patient, right? So if that patient is admitted and the nurse practitioner, PA, or CNM works that patient up and say they have enough for a 99222. In the oldie days, prior to this year, all the doctor had to do was come over, do an attestation. Again, it's only Medicare Advantage plan. They could just do a little paragraph summarizing what went on, summarizing the exam, blah, blah, blah. And that was considered still billable under the doctor's number. But that rule went away in 2021. So from 2021 moving on to the future, we have to have both providers sign the note and put their time. Well, they have to both document something and just write their time. So whoever spends the most time with the patient on that day is the NPI number we send it out on. Medicare basically said we're sick of paying 100% for hospital visits. And this, again, I want to stress to you, is only the hospital. The Incident 2 rules in the office still apply. But in the hospital, whoever spends the most time with the patient gets to bill under their NPI number. And so CMS is like, we're tired of paying 100% for a stupid attestation and a doctor who maybe just stuck their head in the door and spend a little bit of time with the patient. If you're doing a team meeting, only one person's times count. So if the nurse practitioner is talking to the doctor about the patient, only one of those can count up the time. Both providers on the note, the billing provider must sign and date, and the billing provider is one that spends the most or substantial time with the patient. And that's where this FS modifier comes in. So if you have a Medicare population in your area and you see a patient with again, it's only in the hospital and it's only shared visits with a mid-level and a doctor on the same day. Now, once this rule came out, all the employee physicians lost their mind because they're paid on work RVUs, right? And that just meant, the average work RVU is, $60, $50, $70, depending on where you live. So you were literally going to lose, that $140 on a 2 work RVU code. So what Medicare said was, this is the rule forever and ever moving on until we change it again. However, we will give you 1 year to prepare, for this change in your salary contracts, which is exactly what happened. So that's called the optional documentation rule. Now, this is only around for 2022 while your contracts are rewritten. And a lot of new contracts don't even include work RVUs anymore. I think hospitals have figured out that, you put somebody on a work RVU, maybe they don't understand coding, and we're seeing all these denials on the back end. So they're switching their contract methods. Some are. Yours probably wouldn't be, but under 2022, we can bill on the new rule, which is who spends more than half of the time with the patient, or if the physician goes over and sees the patient on the same day as the mid-level saw them, the NPP, non-physician practitioner. And I got to be careful with that because everybody's sensitive about what to call a mid-level. So a lot of times you'll hear me say NPs, PAs. It's like that Netflix memo that went out. You have to be super cool about how you talk, so don't take offense to how I'm doing it. If the doctor goes over, looks at the nurse practitioner, PA, certified nurse midwives, and they document a complete history to support that level of service. So if it's a 99222, they'd have to do chief complaint, 4 HPI, 10 review of systems, medical, family, and social history. Or you could do the complete exam. So the nurse practitioner does her 8 organ system exam, right? Or her GYN specific exam. The doctor has to come over and do their own exam. The key is down here, it says in its entirety. Or the doctor can write their own assessment and plan, but it ain't, I agree with the nurse practitioner. You have to literally do it like you do it if you were the one doing everything. Now, what most of my private hospital docs do is they just repeat the exam. So at the bottom of the nurse practitioner's note, they will say, attending Dr. Smith, right? Attending Dr. Smith, my note. And they'll do a little summary paragraph that says, hey, Mr. Jones was admitted yesterday for this, this, and this. I agree with the decision plan made by the nurse practitioner. The following is my exam. And they'll do the exam component, and they'll do their own 8 organ system exam. You can't get lazy, though, and just copy the mid-levels exam. You have to do your own, and it should be a little bit different. But this is the way that you can bypass the new rule about more than half of the total time. If you go to the hospital, though, with a mid-level, starting in 2023 for all Medicare patients, whoever spends the most time with the patient is the number we build it out under. So this gives you a little bit of a break while you go to your CFO or CEO or hospital administrator and talk to them about redoing your contract. Here's a list of where that comes from. So here's the E&M Visit Family Code. So 2022 definition of a substantial part. This would be more than half. And this will be 2023's rule. See how everything here says more than half, more than half, more than half, more than half. And here they give you in 2022 the option to do this. Okay, the 3 criteria. If you're in the ER, inpatient observation, hospital, skilled nursing facility, or other outpatient services. Now, outpatient services, remember, you don't maybe know this, but Medicare eliminated and Advantage eliminated shared visits in the office. Do not misunderstand me. There was a small exception in the shared visit rules that would allow you to share a visit with a nurse practitioner if you both saw the patient on the same day, if you did the same thing I just talked about. You did one of the key components on your own. I've only had in 25 years 2 doctors do this, and literally they were having the nurse practitioner kind of present the patient like a resident would. Most people don't do that because it's counterproductive. If you do it, then I apologize, but really you're paying somebody $90,000 a year to see patients. The expectation is you don't have to go into the office and see every patient that he or she sees. So they're not talking about that. What they're talking about are some of these observation codes. Because if you look at 99213, 99214, those codes say office or other outpatient service. So a lot of people don't know that if you're the GYN on call that weekend, you're a man, a woman calls with a GYN problem, you don't have a chaperone, you might say, well, hey, listen, go to the ER, check in there, and then I'll come over and see you as a courtesy in the ER where I have a chaperone. Well, you still would bill, even in the ER, your 213 or your 214, your place of service would be ER. You'd have a chaperone. But again, they're telling you those are the kind of things that are other outpatient services, and they bring that up here, right? If you did a consult, which CMS doesn't pay for anymore, you still use 99202 to 99215. So if you're asked to consult on a patient in the emergency room that you don't subsequently admit, and you're not an ER doctor, they're going to let the ER doctor bill their ER code. And, your expectation is you might bill an outpatient code. Now, there is this really weird little rule that will allow 2 people to bill ER codes on the same day, but normally you would just bill an outpatient office visit 202 to 215. Okay? Look at that, how nice they are. They even put the acronyms down so you know what they mean. That's cool. Reporting prolonged services for Splinter shared service, other outpatient, inpatient. Again, this is 2022, which we've already talked about, and this is 2023. So The G2212 is the 15 minutes over the top of the food chain for that code. So if you went 69 minutes on an office visit, you'd bill the 99215 with the G2212, which we're going to talk about in a little bit. All right. So these rules are very important. So if you need to get a picture of this slide, I'll hang here for a second. But this is normally stuff that most doctors don't do, but they might do. Because very few doctors bill the 99354 through the 99359. But technically, even if you were in the ER as a courtesy and you were going to bill it 214, you could still do that on total time. But there we can combine the times of both practitioners to meet the threshold. That's the exception here for G2212, because this says prolonged services for split or shared visits, which I've never seen anybody do. And then again, for 2023, it's whoever spent the most time. So if both of you, if the nurse practitioner spent 60 minutes and the doctor spent 10 minutes in the ER, then you combine those together and you get your 60. Did I say that right? 215, the nurse practitioner spends 60, the doctor spends 9. You add their two times together to get 69, but the claim has to go out under the person who spent the most time with them. So if it's a hospital ER visit or an outpatient consult visit where you're using outpatient E&M codes, you'd have to bill based on the provider who spent the most time. So the 99215 and the G2212 would go out under the nurse practitioner in that scenario. All right, so I know that this should not be called Peace for Mom, but this is the video that the GA OBGYN wanted me to show you as we get near the first break. So we've been going for about an hour and 15 minutes. I'm moving along here. So I'm going to play this video real quick, give you a little bit of a break because I just saturated your brain with a lot of stuff that you might not ever use, but it's important to support I have to submit an agenda to give you 3 CEUs. So I have to be honest because there are some people out there who will turn you in, God forbid, if you give a 3-hour CEU for a 1-hour course. So I'm going to start this video, get your coffee, watch it. After you watch it, and then I'm going to give you, probably come back. I think this video is about, let me see how long it is real quick. I just clicked on it. Let's see, here it comes. It is 10 minutes long. So if I give you, let's see, 5, 10, and then I give you a 5, 10. Okay, so I'd expect you guys to watch this video and be back in your seats by about 10:25, okay? 10:25. Here we go.
Addressing the issue of maternal mortality in treatment due to race, cultural group, or language. Black women are
Oh, shoot. What happened?
He's come to Boston for the springtime. Staying here with some friends, and they've got lots of room. You can sell your paintings on the sidewalk. Buy a cafe where I hope to be working soon. He's come to Boston, she said no. Will you come home to me? And she said, hey, Ralph been born out. Boston ain't no kind of town. Ain't no gold and there ain't no money. I'm the #1 fan of the man, Tennessee. Come to Denver with the snowfall. Into the mountains so far that we can't be found. And throw I love you echo down the canyon. And then lie awake at night till they come back around. Please come to Denver, she said no. Boy, will you come home to me? For one thing, man, Tennessee. Now this drifter's world goes round and stuff. But of all the dreams I've lost or found, and all that somebody I can sing to LA to live for. California life alone is just too hard to build. I live in a house that looks out over the ocean. And there's some stars that fell from the sky, living up on the hill. Come to LA, she just said no. Boy, won't you come home with me? Go, nobody likes me. Oh no, #1 fan, man, Tennessee. #1 fan of the man from Tennessee. Yacht Rock 311. Light in your head, there don't be well enough. A crazy day, you'll drink the night away and forget about everything. This city bears dimension, it's so cold. So many people, but it's got no soul, and it's taking you so long to find out you're wrong. I think that it was so easy. You used to say that it you're trying now. Another year and then you'll be happy. Just one more year and then you'll be happy. You're crying, you're crying now.
All right. Much as I hate it, I'll have to turn off my yacht rock and get back to work. That's my favorite station on Sirius XM. All right, so we're halfway through. Thanks for watching the video. Yeah, I just got an email from somebody in the room chat. Yeah. Well, you know what, Marissa, if you hold on, I'm going to go over some more coding stuff for E&M. But if you send me an email, I could send you like my preventative coding seminar. It goes into a lot more detail. I also have a seminar called The 30 Most Common Errors and E&M Coding. So yeah, if you send me an email, I'll hook you up. And my email will be at the end of this talk. Okay, so now let's see if we can spend some time talking about evaluation and management codes. Some things you know, some things you might learn for the first time today. There were 15 code changes in the E&M section. But don't let that scare you. Normally when I do this talk for ACOG in November, I talk to them about what to avoid when you get coding seminar emails. And I crack up because I read the book in October and I kind of know what's happening. But, you'll get these emails in November, December that says, are you aware of the 15 changes to E&M codes for 2022? But then when you look at it, really the only thing that changed was 99211. That's 99211 is a nurse visit, for the evaluation and management of an established patient. That let me get my highlighter on here. I hope you guys can see my highlighter. That may not require the presence of a doctor or other qualified healthcare professional. And they just took out usually the presenting problems are minimal. Now, I'm a nut when it comes to 99211. And I think it's, you can't use it if somebody just comes in for blood work or just comes in for an ultrasound or just comes in for an x-ray. The general rule is 99211 is going to be billed by itself, and that was something else. So if your doctor orders a repeat blood pressure, the patient comes in and gets a blood pressure check. Another common example is if you think somebody has a urinary tract infection, they come in and they drop urine and, you find out that they do have a UTI. The nurse goes to the doctor writes out a prescription without seeing the patient and gives it back to the nurse, who then writes a note. He's got to have a note with this and gives the patient the prescription for the medication. That's an example of when you could do a 99211 with an 81103, 100, 101, however, whatever you code it. But just kind of remember, you do need a note. It does need to be signed. And just because this is the biggest, it's the biggest funny thing to me as a coder. But Steve, we do a blood pressure check when a patient comes in to get an ultrasound. So a blood pressure check's all I need, right? No, it's inconsequential. You can do a 99211 with a patient without doing a blood pressure check. So just kind of be cognizant. If you're billing the crud out of 99211, you're doing it wrong. I can just assure you of that. So kind of, you know, I wouldn't always necessarily go by the CPT book for that definition. Just know that a lot of insurance companies don't recognize the CPT book because it is, where's this at? Because it is written by doctors for doctors. So a lot of the stuff, even stuff that they write in there about incident 2 is not necessarily true when it comes to most insurance companies in the state of Georgia. I hadn't planned on saying this because I don't want my inbox to blow up, but I want to encourage you because now it's like Cigna, United Healthcare, Blue Cross and Blue Shield all want your mid-levels to be credentialed now. And technically, you're supposed to be billing services out under their NPI number because, again, they want to do what Medicare does and pay 85 cents on the dollar. Most people have not been aware of that yet. But if you look at their websites, especially UHC and Blue Cross Blue Shield, this is a rule that went into effect last year. In the past, they didn't recognize mid-levels. Now, here's the caveat. If you're part of a big hospital system, sometimes Blue Cross and Blue Shield, United Healthcare will grandfather you in, and all you have to use is the SA modifier. If you have any questions about that, you can always go to the Blue Cross, just type in Blue Cross Blue Shield, NPs or PA, same thing with UHC, and you'll see the policies. Don't everybody email me. I'm having a terrible week. But if this is something that's brand new to you, you're in a private practice, I have a file that includes all those policies in it. The same thing holds true with Medicaid. Medicaid requires everything to be billed under the nurse practitioner or the PA. There are no exceptions to that. And what happens is a lot of times we read in contracts that we can do incident 2, but there's 2 types of incident 2, right? There's incident 2 where a nurse gives a shot, and as long as the doctor's in the building, they meet the criteria for incident 2, and there's documentation of the service. And anything that a doctor wants to bill under their number that's done by somebody else, they have to sign that incident 2 note. Okay? Now, then there's incident 2 when it comes to E&M codes. And most of the policies impact CNMs, NPs, and PAs. So the first type of incident 2 has just always been around, and that's staff doing things under the supervision of a doctor. But then there's E&M incident 2, and we forget to separate the two. So I have those policies. How about if I do this? I'll send those policies to ACOG so you can look at them, okay? That way ACOG can send them out en masse to everybody who's on them. So you'll get the free ICD-10 link, a bunch of information on incident 2 in the office, because office is incident 2, hospital is shared visits. So I still run into OBGYNs who bill all of their nurse practitioners and PAs under the doctor's number, and that's just wrong. And you know how you normally get caught? Because if you have a bunch of nurse practitioners, Medicaid goes, how is this guy seeing 80 patients a day? Maybe you ought to look into that. If you get busted for violating the rule, which you probably won't, but you still need to do it right now that I've told you. The worst case scenario is they just take back the percentage of the difference between what would have been paid under the NP and what was paid under the MD. So for Medicare, you might get a 15% overpayment. For Medicaid, I think they're doing 90% now, so it'd be a 10%, something like that. Okay, so that's how that thing works. So that's the biggest one that's going to impact you. A lot of other E&M codes are things that are not done by GYNs, like chronic care management, etc. Those kind of minor changes. The important thing is to know how to do data. So when you're looking at an E&M code, we look at, level 4s is where people want to go now. The level 4 has a high work RVU, even though the commercial plans, commercial insurance, not commercial Medicare Part C, have caught up. We still have this high work RVU. that is supposed to be paid to you under your contract, but most hospital systems did a moratorium on changing the work RVU system and keeping the rate at the oh my God, we're in the 2020s. They kept the same rate as 2020, because 2021 is when they upped all the work RVUs for outpatient E&M codes. And that's probably why, if you haven't yet gotten paid under the new RVUs, which are established by Medicare to help figure out what they're going to pay you, that's normally what your work RVU contract is based on. But if you look at the work RVU update, some like 214s and 215s went up 25%. And that just makes it really difficult, because if you have Blue Cross Blue Shield, their rates didn't go up 25%. So that's a big thing. So when we're looking at level 4s, all insurance companies follow the CMS guidelines. And this is just a document that I created to teach from that I think is really easy to understand. The thing that got changed the most was this section called the data. Now, when we're looking at the table of complexity here, there are 3 columns. You're required to fulfill the elements out of 2 of these. So, here's your first column, here's your second column, and here's your third column. Now, we'll talk about social determinants of health in just a little bit, but let's just talk about category 1, category 2, and category 3. Now, just because you meet the criteria in column 2 doesn't automatically give you the opportunity to go level 4, because again, you need 2 of these 3 columns. But this is the one that confuses most coders. So category 1 says that you have to have 3 points from any of these 4 bulleted areas. Okay. If you review outside notes, if you're seeing a patient and you request and you review the records for the cardiologist, you review the records from the nephrologist, from the psychiatrist, that would be 3 points, because each unique source means that. Now, if this patient was going to a cardiologist and you reviewed records from one practice, and she had seen 4 doctors and mid-levels in that practice, because it's one practice, you only get to count that as 1 point. If you have a patient who comes in and has had outside lab done, labs that you didn't order, that's critical, you can count those. So each unique test means that, a patient comes in and they bring you, like, I have a new family practice doctor, right? So I brought in my LabCorp. You'd love me as a patient, not as an OB because I'm a guy, but I have a list of all my diseases, all my ICD-10 codes for those diseases. And I've also lined up what drugs I take and how many milligrams and how often. So when I go to check in the first time, when the nurse is writing me up, I can show her all my stuff and she doesn't have to ask me how to spell Wellbutrin or Farxiga or anything weird that I take. But if you review their labs, like my doc did, he looked at my lipids, he looked at my A1C. This was from my previous doctor. And even though they're under the same umbrella with Piedmont, because Piedmont now is invested or infested, however you want to look at it, the Augusta area, which is where I live. So I went to one doctor who was University Health. She was great. Her staff was terrible. And now I transferred over to my wife's doctor. So even though she was an internist, they're separate groups, and they share the same ER, but because the same EMR. So he got a point for the A1C, and then I had a CBC done for some reason. And then I also had my 24-hour urine, so for my diabetes. So, here are 4 points, because those are 4 unique tests. But that has to be labeled. Outside labs showed the following. If you order a test, it's the same thing. If you order a test during a visit, each unique test that you order is worth a point, unless you're being paid on a code that has a professional component. So let me just explain that again. There are tests that are called results only, which are labs. You can get all the points you want for ordering labs, whether you do them in your office or they're done by a laboratory outside. You get credit for those. You only get credit for them one time, though. So when my doctor, all the labs that he ordered, because I hadn't had labs since September, all the new labs that he ordered during my visit were only for that visit. When I go back and see him in 6 months, when he reviews that, none of that time counts. None of that, none of those points count. That's why I want to stress to you, outside records, and that would include things like even an ultrasound, infant MRI, a CTA. It doesn't matter. If you review it, you get credit for it. Long as you label it as outside. I have to be specific because sometimes people misunderstand me because they're learning so much. And then they'll call me and say, did I hear you right when you said, and I'm like, no, you didn't hear me right when I said that. You heard me completely wrong. That's why I record my seminars now. If you have to get history from somebody other than the patient, that's a point. So if the patient has dementia and you have to get history from somebody else, if it's a young girl that you're seeing for the first time and for some kind of problem, and you get the history from the mom, that point counts. So as you can see, it's not difficult, as long as you document properly, to meet the criteria for category 1, because you only need 3 points here. You only need 3 out of these 4. You can combine them, so you can get, you can order 2 labs and get the history from somebody else, and that's 3 points. You can review external notes for a point. You can review outside imaging and x-rays for a point. And then you can order something for the first time for a point. So you can mix and match all you want. Now, the next thing that we'll talk about is going to be category 2. Okay. Now, category 2 is always been around, and it just says that you do an independent interpretation of a test performed by another physician that you are not billing for. So there's result-only tests, which are labs, and then what you don't get to count is anything that has a professional component. So most imaging will have a professional and a technical component. And if you bill global, it still has a professional and technical component. So most imaging services are not result only. They require an interpretation from a physician. Now up here, if you order a test that has a professional component, you don't get to count it. Because CMS, Medicaid, Blue Cross, United Healthcare say, why should we pay you for the test and give you credit for it so you can bill a higher E&M? They just don't do that. This normally impacts the greatest in orthopedic surgery, where they might have a CT scan, an MRI, and an imaging service on site. Because all the tests that they order, I can't count. All the independent reviews that they do only count if you write what? Outside, right? Outside images showed the following. And it has to be more than just results only. You can't just write down, it showed normal this or normal that. You have to kind of elaborate on it. You don't have to do the same thing as a pathologist, but your note should read, I personally reviewed the images that revealed the following. So if you don't say you personally or independently reviewed, they won't count it because it technically would be a test up here, right? If you wrote outside imaging showed the following, that's all they're going to give you. But if you say outside imaging that was personally or independently reviewed by myself showed the following, that's when you meet category 2. And you have to say that. A lot of times doctors struggle with this, but this is kind of easier than doing taxes. I mean, I have to have a CPA do my taxes, and I still get audited. We give a lot of money. It's so embarrassing how much money my wife gives to charity. So when we report our IR, and some of you go through the same thing, you need to look at your tithe, St. Jude's for women out in Las Vegas. Oh my God, she gives money to everybody, and we get audited even though we use a CPA. So it's really easier than that. So you just kind of have to remember these key words. Now, the next thing that we're going to talk about is category 3, which also can be used to help you support a level 4. Category 3 is really good for GYNs because you have to discuss a discussion of management or test interpretation. And that's the key. There's two options. You can either talk about patient's management or the test interpretation. Now, the test interpretation means that you're going to pick up the phone and talk to the person, the doctor, the NP, or the PA that interpreted the test results. So maybe it's you have a question about a CT or an MRI. If you document that you had a synchronous conversation, you can't use an intermediary. You have to talk to that person individually, not the nurse, not tell the doctor I said this. You have to be proving that you talked directly to the performing provider. The other option that you have is management of the patient. They list what appropriate sources are. They're not healthcare professionals, you're right, but they may be involved in the overall management of the patient. So a lawyer, a parole officer, a case manager. My wife's a teacher. She has a lot of conversations. She's a kindergarten teacher. So she has a lot of discussions with pediatricians about ADHD, stuff. And the doctor, I hope, writes down that discussion of management with child's teacher revealed the following. He is acting better in class, which none of them do. We went to a Green Jackets game. That's our minor league baseball team that's affiliated with the Braves, because it was school night. And I met so many cute little wonderful children that were kindergartners, and my wife was like, oh my God, that kid is terrible. She's got one kid in class that eats hand sanitizer, that eats through her mask when they were wearing masks. She eats tissue. She's really defiant, but that's okay because she's a foster child, right? So there's a lot of work that providers have to do for that child to try to figure out what's wrong. So they might talk to the foster care agency, her case manager, they'll talk to the teacher. All that stuff's documented and it's legitimate to use. Okay. The next thing is, so I told you we needed two of these three columns, right? So if we have this column and we look at the risk column. Now the risk column has a lot of information in it. So, there's prescription drug management, right? So let's just say that you ordered 3 tests and you wrote a prescription or the patient's on a medication that you prescribed. That could be a level 4, right? Because you've got this column and this column. Decisions regarding minor surgery with identified patient or procedural risk factors. Now, in the old days, major and minor was dependent upon the global period. So minor surgeries, no matter what they were, where they happened, were 0 to 10 days, and majors were 90 days, plus the day before and the day after, the day before and the day of surgery, which really made them 92 days. Now, under the thing that was sad about that was heart caths are 0-day global periods. Colonoscopies are 0-day global periods. Colposcopies are 0 day. So there's a lot of codes out there that could be considered major surgery, but the global period was wrong. So what CMS did was they said, well, this year, we're going to let you decide whether a surgery is major or minor. And if it's minor, typically those are things that you do in your office or without anesthesia. That's just a general, without local, you can still use local anesthesia. So, I had a seborrheic keratosis frozen off. I hate getting older. But I had a seborrheic keratosis removed from my head with liquid nitrogen a couple weeks ago. That's minor surgery. Even though I'm a diabetic, did it in the office. It was quick. And even dermatologists understand that. But if you're doing any kind of surgical procedure in your office that requires some type of anesthesia and the patient has identified risk factors and you document that, then that can be considered level 4. So you get to do whatever you feel is acceptable in the world in which you live. So we really hoped that ACOG would put out a list that says, okay, we consider this minor surgery, but you could code it as minor surgeries with procedural risk factors if you did this. And here's a list of things that would make a minor surgery have and a patient at risk, right? So it's really important that you just run a CPT productivity report with your staff and look at your top 10, surgeries that you do. That's going to generate most of your money. And then just next to it, write, okay, this is minor, this is minor, this is major, this is major, and this is minor. And then you do a column that says, and you only have to do this for the minors, really. Procedural risk factors, what are they? What are the procedural risk factors? And you can't, I'm not a doctor, so I'm not the one who's going to judge you on post-payment review. There's going to be another doctor. So you have to make sure that if you say something's a minor surgical procedure with identified risk factors, you have to list that in your note. And then you also have to know that someday somebody might look at that. Again, I'm just going to go back to dermatologists. If they take off a skin tag on a diabetic and she says, oh, well, that's patient identified risk factors. I'm like, really? Come on, really? No, I don't think so. But if you do arthrocentesis, amniocentesis, maybe on a patient with diabetes, that might be a minor surgical procedure with risk factors. I don't know. You have to kind of figure that one out on your own. If you're doing it outside of the office, typically they'll look at those as major surgeries. Now, in the old days, those used to be things with 90-day global periods. So the form that I use, which apparently I'm going to have to send you all, so let me write that down. I use a form that I give to all my private clients, and I say, listen, dude, I'm not a doctor. This is on you. So you're going to tell me what's minor with risk factors and what those risk factors are. And then you're going to tell me if it's minor with patient risk factors and what those risk factors are. And then we're going to make a template. So every time you order this procedure, if you do, for example, an arthrocentesis or an epidural steroid injection on a diabetic, that makes this procedure more minor with patient or surgical risk factors. And here they are. Pain management doctors tell me there's incredible risk with even doing something as simple as a trigger point. So, we got to look at that. So they don't, they consider trigger points procedural risk factors because of all the bad outcomes that can happen with those. You have to make that list and don't count on your coder to do it. So I'll send you guys the form in that big email that I send to ACOG today. You also, most of the stuff you do in the hospital is going to be considered major surgery because there's going to be anesthesia other than local. But it doesn't really matter if, they have risk factors or not, because you're not usually ever going to get enough to support a level 5 visit unless you do it on time or unless you send a patient to the hospital. Look at this. Diagnosis or treatment options. Oh my gosh. Diagnosis or treatment options based on the social determinants of health, right? And this is new for 2021. That's why I said you should look at your Z55s and all the way through Z65. I'll show you a slide in just a little bit. But maybe you ordered 3 tests and the person's homeless. So you got 1, 2. Or you reviewed 3 tests from the emergency room, And you write the results in your note, outside lipids showed this. Outside CBC showed this. It seems like a lot of work, Steve. Well, it's going to help you support a level 4, which pays about $120 even for Medicare. Most of your commercials don't pay that much. But yeah, it's worth it. It's worth taking a minute. It's worth keeping all my receipts. My wife got me the best gift a guy like me can get. I love movies. And like to my right is my Al Pacino Scarface collection set, and I love Scarface. I love Al Pacino. So she got me a signed autograph from Scarface. And say hello to my little friend. I love that. And she bought that from a charity auction, so it was deductible on our taxes. We keep those receipts. We keep as much stuff as we can because we know we're going to get the return. So we're helping out a home for women who have been in the sex trafficking trade, and we also get a tax credit for that. It's good stuff. So keep your stuff and don't think of it as just being too difficult. Write these things down. You'll be better off in the long run. There's your social determinants of health, and here they are, right? So, it's in this slide presentation. So, problems related to education, employment, occupational risk factors, housing and economic circumstances, their social environment. Problems are related to their upbringing, right? support groups, family circumstances. You might have patients who get no help from their family. Psychosocial circumstances, right? So there's two categories for that. You just take your ICD-10 book if you're a staffer, copy these 3 or 4 pages, give them to your docs, make sure they're in your EMR, which they should be because they're legit ICD-10 codes. And heck, I mean, if you wanted to, you could even have, when the nurse writes up the patient, which she probably wouldn't feel comfortable doing, you could pick 4 or 5 of these that are common in your area. And she could say, Stephanie is a 53-year-old homeless patient that we're seeing today for the following problems. Because we can code from stuff that's not written by the doctor. Now, I still like to see that in the assessment and plan, but I don't know who has access to your assessment and plan. And as a coder, we can code from the history of the present illness. We can code from the physical exam. We can pick codes from the impression, assessment, and plan. So I would suggest not having your MA do it, even though technically they could. But I would just get the doctors to understand what these are and that these are substantially a credit for us to have. Some 99214 reminders, right? That's the code everybody wants, so let's just kind of review. If you're going to build any E&M service, you have to remember the most important component is why the patient is coming in, right? So you can't just say 3-month follow-up, no complaints, med refill. You have to list everything the patient is coming in for that you're going to treat. The only exception to that would be if you found something in the review of systems or the exam that the patient didn't think was significant, but the doctor did. So, I'm so sorry. You've caught me at this time in my life where I'm going to the doctor a lot, but I had an infected fingernail, right? So I just went to the doctor on Monday because the pain got so much, right? He numbed my finger and he aspirated the pus. It's 100% better. But on my intake sheet, I'd mentioned that I have a rash that's just kind of developed. And for some reason, as the PA, that was significant for him with regards to the antibiotics, and then I'm allergic to sulfa. So there's stuff that he found on the physical exam and in the review of systems that, I didn't say I was there for, but it really helped to, for his diagnosis coding. So that's where the exception comes in. And each assessment should have its own plan. So a lot of times doctors will write everything they're going to do under one diagnosis. And you can't do that legitimately. Now, you may get paid, you may never be audited, but my job is to tell you what's right and what's wrong. So I'm kind of like your coding preacher. All right, next thing that we have to make sure we do. This is really important. When it comes to 214s, one of those 3 columns that we haven't talked about yet is the number of problems addressed. Now, typically, we're going to focus in on chronic conditions, and you have to know the definition of what a chronic condition is. So a chronic condition is something that's expected to last for at least 1 year or until the death of the patient. It's not how long you've had the problem, but it's if it's chronic or not, you expect it to last for at least a year. So I see a lot of GYNs who treat problems like that, like migraines. And if they don't go to a neurologist for that, but you're managing that problem, and they come in with a migraine, and it's a chronic problem, and it's not at goal, right? That'd be a chronic condition, acutely worsening. Again, what I would do if I were you is run an ICD-10 productivity report. And it's going to show you your top 25 diagnoses, right? Just simply, just grab a PA, grab a nurse practitioner, grab lunch, and just let the doctor tell you as the coder, this is chronic, this is not chronic, this is chronic, this is not chronic, and this is chronic. And make a template that you would put underneath each of those diagnoses so the doctor could do a quick text, or some kind of box that would open up, and then under that diagnosis, you might have to write something like, okay, so the patient's got a migraine, all right? And then a template would say, this condition is to last at least for a year. That would be under it to show that this is, pertinent. And then next to that, we have to tell you if it was worsening or at goal. So I like to use at goal, not at goal, but doctors are like, come on, that's ridiculous. If I say stable or worsening, does that count? I'm like, yeah, but technically, remember, if you see a patient with an OB patient with elevated blood pressure, I know this is probably going to be part of the global, but and her blood pressure was worse. Now we know things like hypertension, diabetes, arthritis; those things are going to last for at least a year. But if she came in and her blood pressure was 180 over 90, and you put her on some new meds, and she came back a week later and it's 170 over 90. Now that's improving, right? But it's not at goal. It's not at goal. And that's just improving. There's no room in the system for improving. So they're either at goal or not at goal. And that's why this is important to use, because you see patients sometimes who you treat for a medical condition, you see them, they're getting better, but they're not where you want them to be yet, right? So that's why we recommend at goal, not at goal. And that's also kind of the definition in the AMA book that CMS endorsed for the E&M codes. So remember, we're looking for chronic conditions that are expected to last at least a year would be one consideration for a level 4. You really should think about at goal, not at goal. And you really want to do this with, GERD, anxiety, depression, pain. Sometimes people have anxiety for just a little bit. I'm anxious because I got to get on a plane in a couple weeks to go out west with my wife to see my son, and because he lives in Las Vegas. And so my anxiety sometimes is temporary, but, my bipolar is chronic, my bipolar depression is chronic, but sometimes people have depression for just a season. Somebody dies in their family, they have major depression, single episode, and, it's not going to be there for a year. So when you have these conditions that aren't necessarily long-term systemic diseases that are obviously going to be around for a year, you really have to focus on that. I used to have GERD, but I took some over-the-counter medicine. I stopped drinking 2 or 3 cups of coffee a day, and it went away. So it was a short-term thing. Other people suffer with that forever. That's why I stress this. That's why I stress you should make that list with your doctor and maybe on your top 20 diagnoses, and you can write it on the report. You don't have to make anything special. You can write it on the report, make it one template that just says chronic condition expected to last for at least a year. Hell, you could even do that for at goal and not at goal. So you could say, this is a chronic condition expected to last at least a year, not at goal. Second template would be, this is a chronic condition expected to last at least 1 year, at goal. And then your doctor could quick text that, or your nurse practitioner, or your PA, under those conditions that they identified were chronic. Okay? It just takes some work, and nobody has time. My afternoon is full today. This has just been one thing after another for me too, so I understand. Let's see. Also, remember, we just reviewed all the Category 1 stuff, the 3 points. That's always important to tell me if it's an outside lab or image. Is it independently reviewed? If you're going to try to get credit for reviewing something, you should say, this was an outside technical review. I personally reviewed the imaging, because remember, you don't get credit for procedures or lab X-ray imaging, MRIs, CTs, because those have a professional and a technical component. And even if you build a global, you're getting paid for a professional component, and insurance companies are not going to pay you. You can't double dip. And these rules are mandated to be accepted by all insurance companies. And that's why, like in other specialties, Blue Cross and Blue Shield is just, without even looking at the notes, downcoding them to a 213. And that's a pain in the butt, because now you have to appeal each one of those. They didn't write the book. They had already set out their goal for what they were going to pay every year for 214s. And now, instead of 40% 214s, a lot of doctors are up to 60 or 70% based on the new rules. It's a lot easier to get a 214 than it was in the past. So, I think Blue Cross's hope is that, okay, we'll pay you less, and it's just such a burden to send in the notes and appeal this decision that most people just won't do it. So if you're a doctor, you just want to make sure that you're checking with your staff and, hey, are we getting denials from Blue Cross or Cigna for our 214s? And if so, are we appealing those? And it's a lot of extra work that nobody wants to do. So I'll say this, if you're somebody who's not doing them and your doctor's on this call, I'm sorry. I'm really sorry. Under the third column, we talked about prescription drugs. We talked about making the list of what's major and minor. Anytime you're doing open procedures, laparoscopies, things like that in the hospital, those are always going to be elective major surgeries under the guidelines of the AMA and CMS. Time, okay? A lot of GYNs specifically forget that the rules for time changed in 2021. You used to have to only do, I spent, 25 minutes with the patient, greater than 50% of that time was face-to-face talking about the following, right? But then you didn't get any credit for the time you spent before you saw the patient or after you saw the patient. So CMS listened to all the complaints from the AMA, and now they turn time into what's called total day time. So it's any time that you, as a provider, MD, DO, NP, PA, CNM, it's all the time you spend on a patient in a given day. So, I see a lot of doctors in your specialty, nurse practitioners in your specialty, that are sitting at their dinner table at night working on the EMR. And it's just like, are you counting that time? Because that's total daytime. And that time can be useful for you, right? Maybe you order a record request from somebody, you document that, and it's, 9 o'clock in the morning, your staff calls, and then they fax you over, 100 pages to review. And you review them that night. That is total daytime. So you can add that to the time you spent doing the E&M. This is the time range. Now, you don't put ranges in your note. You pick a specific time. You also don't use the same time on every note. I just did a big audit of a critical care service, and every critical care note that this one provider is seeing, 35 minutes, hundreds of those. Well, if you get audited and they see the same amount of time on every one, they're going to question it. You also want to be honest. I've had 2 providers since 2021 who were subsequently dismissed from the hospital. They were there maybe 3 hours seeing patients, but on the 10 patients they saw, they wrote 40 minutes. Well, they weren't there that long. Their notes were closed out, and it happened on every patient every day they were there. It's insane. And he was actually turned in by his nurse practitioner. So she called the compliance department through their compliance program and said, he's writing this on every patient. And there's no way he's in and out of there in 5 minutes. And he documents his notes, and he just wanted the 215s. Why? Because of the work RVU. So you got to be honest. You got to make sure that you legitimately write down the estimate of your time. You can make a template, but it really should have a drop-down box that says, 30 minutes, 31 minutes, 32 minutes. And probably the only time you bill on time anyway would be if you don't have enough medical necessity already in the notes to support a 214. So maybe you just spent 32 minutes with somebody who didn't have a very complex problem, but you were counseling them, doing education. So your decision making would have supported a 3, but your time supports a 4. That's when you think about it. You also want to remind your doctors that if, I had some doctors who were still a little confused about this, and they were billing for a 214, and they wrote down total daytime 45 minutes. And I'm like, okay, you just wrote total daytime, what you did for 45 minutes, that supports a 215. Your decision making supported a 214, so you can bill whichever is going to give you the best code. When you bill on time, you're not telling anybody that you're billing on time. You're just billing the same codes, but you have to document your total daytime and what you were doing. And again, it can only be the doctor, the NPs, the PAs, and the CNM's time. It can't be staff time. It can't be waiting times. Here's a list of the 9 things that the AMA says that you can counsel or you can do as part of your total daytime. So, you know, if you look at notes that morning, you can't look at them the night before because that's not the same daytime. Be prepared to see the patient, reviewing your history notes. You get to count the time you're doing your history, exam, and decision making. They don't put history on here because most of the time that's done by staff. But some doctors, you know, I go, do you have an MA? And they go, yeah, that's me. I'm the MA. I'm the MD. I do everything. Or some doctors say, I don't trust anybody to do my history other than me. If you do education, that time counts. All the ordering. And you'll also notice that some of these things would help you support, you know, maybe a level 3 or a level 4. Referring and communicating with other healthcare professionals. This is the biggie. Documenting clinical information in the health record on the same day counts as total daytime. And that's why I'm telling you that if you have a nurse practitioner, a doctor who takes their work home at night because they're seeing so many patients and they talk to patients, they're very diligent, but they don't have time to do their notes until they get home that night, that time counts. Independently interpreting results that aren't separately reportable, that means that you're not billing for them, or you're communicating results to the patient, family, or caregiver on that day. So maybe you order some stat labs and those labs come back. This, and you talk to the patient on the same day. This does not require face-to-face time. Okay, they changed the rules because doctors said, well, it's great that I get to count the time that I'm in the room with the patient, but what about all the time I spend on that day reviewing their records, looking at outside notes, ordering their tests, documenting them in my ENR, calling the patient's family at the end of the day to go over things with them? All that time, if it's done by the provider, counts. Those 9 things there, we normally want you to document that you did at least 3 of them. At least 3 of these. All right? Here's an example of a 205 note. Right? Greater than 60 minutes was spent with the patient reviewing history and exam. Now, if you think about it, 215 is 40 minutes, right? 40 to 54 minutes. Referrals, hesitance. But this is enough to support a 205 because a 205, I read that wrong, is 60 minutes, right? Now, I don't like that he wrote greater than 60 minutes. So I just, when I audited this record, I'm like, The reason you don't want to write greater than 60 minutes on a note is because you get to use the prolonged service codes if you go 84 minutes for 205, and you get to go 69 minutes if it's a 215, you get to use the prolonged service code. So greater than 60 minutes, I don't know, man, did you go 70 minutes and maybe you could have coded an additional prolonged service code on the same day? I don't know. 215 notes. Two 215s, you'll remember, are back here. Oops. And these times are all listed in your CPT book, but a 215 is 40 to 54 minutes. Now, he wrote 55 minutes. These are clients of mine, and I audit their notes usually once a year. This is a large hospital system of mine that I love. But I do this, like I'm going down to Cordeal Memorial Day weekend to work down there at their hospital. I go to Colquitt Regional. I go to Moultrie, and I audit their doctor's notes. So a lot of these folks are perfect examples of doctors who listen to me. CMS and AMA reemphasize some time rules. Anything that you can separately report. Now, I know you're not doing chronic care management, things of that nature, doesn't count. Travel time doesn't count. I work with a group out in Seattle that is a pediatric mobile office. So they do house calls. Now, the travel time that you spend from here to there doesn't count, right? But what about talking on the phone to the mom before you get there? Well, that's part of your total daytime. But you can't go travel time like I do as a consultant. Like I took a call from somebody in Odessa. I do a lot of work out there. They have a new person, and I let them know, hey, listen, that's a 4-day round trip for me. So I've got to charge you for my travel time since I don't fly. And as long as you're willing to do that, I'm good with it. And some people will pay me for traveling in a car, and some people don't. If you don't, I can't work with you because I'm going to lose 4 days of my life going out driving one of those days through Texas because it's such a big state. Any teaching time, so if you have a resident either in your office, hospital, a fellow, any teaching time doesn't count. So what am I going to confuse you with on this? Very simply. If you write time, if you do total daytime, you almost have to bill like a critical care doctor. You have to say that total daytime was this minutes, let's just say 60, doing 3 things, and then you just write exclusive from other billable services. Okay. So if you have a patient come in for a well visit and they have a significantly separately identifiable problem that you want to bill a 213 for, that's what your medical necessity missing is. You cannot add the time that it took to do the physical plus the time you did the E&M because this is separately billable. This is separately billable services. So you have to say total daytime was this many minutes. Here are my 3 things I did, and that was exclusive from any other billable services on the same day. Because if you bill this 99396 with the 215, and you don't tell me that that doesn't include this, then I'm going to think you're trying to double dip. And there are a lot of doctors who do this, but they don't specify that the time they're using was separate from all other billable services. Now, to go even more nerdly on you, oh my gosh, oh, I'm sorry, my little thing's not lighting up. So let me look at some of the questions I've gotten so far. Okay, I've got Marissa's, will do. Okay, for category 3, will this count if it is done electronically, or does it have to be a verbal discussion? It has to be verbal. They want it to be synchronous, and there's really no guarantee that the documentation of an email exchange might not be synchronous. It also might be that a nurse is using it. So the preferred method on this, the required method, is vocally. I want to talk vocally. Under the ordering of each unique test under data, can you count wet mounts, UAs? Okay, so let's just talk about that. If you don't have this program, I understand, but I'll show you a couple ways you can decide whether or not you can count something. So I'm going to go to my Encoder Pro. All right, so I'm going to do something kind of crazy here to show you. I'm just going to pick an X-ray code, right? 71046 is a 2-view imaging code, right? Now, when I click on it, if it has a reimbursement rate under the 26 modifier, then you can't bill that because that's not a result-only code. If I check a urine pregnancy in 81025, that is only going to have, it's not going to show you a 26 or a TC because the labs are result only. Now, if you wanted to look at that even more, oh, what's this? Oh, that's my imaging thing here. So if I wanted to go to CMS fee schedule, and I went to the physician fee schedule, and I wanted to look at fee schedules here. Oh, shoot, this is the long and hard way to do it. I'll show you how to do it the easy way in Georgia. Palmetto fee schedule. And I'll show you how to read this real quick. This is how you can, oh my God. Fee schedule. Okay, so we want to look at a fee schedule over here where most of you are Georgia 99. So I'm just going to say 2022. It doesn't matter if you are, just say up to 5 procedure codes. Our carrier is 99 Georgia. All right, so here we go. 71046, 76942, which you guys use a lot. Let's just do a lab. 81002, 85025, 81025. Oh, I did that one already. 81. Let's do 80061. I don't know. So we're just putting those in, and we're going to submit it. And looky there. See, anything that has that's split up to TC and 26, even your ultrasounds are going to have that, but these don't. That's how you know. Yeah. Okay. You just go to this website. It's on Palmetto GBA, just like I did, and it'll tell you. So I don't believe wet mounts have a professional or technical component, nor does a UA. I sent this to Steve directly. Not sure how the questions are going to be answered. Let me see. Oh, okay, cool. Saying, Miss Wilson, I answered it that way. Apologize. So you can bill a separately E&M in addition to a well woman, and that's based on a separate E&M on time. I don't encourage you to do that, but if you do, then that is fine. I don't. Most of the time, with a lot of carriers now, if you bill a 99396 with a 214 215, they usually, like United Healthcare, will cut it in half. The general rule is, if you guys have a second, let me show you how you should really, if you want to do that, do it. Just give me 1 second here, and I'll pull this up. And I have an example of when it's appropriate. The other thing about billing an E&M code with a preventative is patients get furious. And they're going to call your office after they call their insurance company, and the insurance company says you did it wrong. And it normally just throws up a lot of, what is this? Oh, it's my HCC seminar. You don't need to see that. Why did that pop up? I went to E&M. Come on. File. Open. Browse. This will be worth the wait here. So, seminars. Oh, I put that in the wrong place. So let's go down here. Yeah. This is always a tricky question for me. Okay, here we go. So a CPE with an E&M. All right. The guidelines under the 2020 rules are fairly significant and the same as they are. Now, I don't like the time thing because I think it's confusing, even if you write it's exclusive. But here's why you could do that, right? If you're doing something after the preventative that's medically necessary, you could do time. You can also do documentation. So here's an example of how you would do this for most practices, and you can put in your own problem, but we want to see something in the history about it, something in the review of systems about this problem, something in the exam, and we want it to have its own assessment and plan. Now, this is a group that I work with gets audited all the time, and they pass every audit from Blue Cross. So we did the preventative physical, right? Oh, and the patient's also complaining of knee pain, right? You can say abdominal pain, pelvic pain, or whatever. So it's in the history. It's in the review of systems, right? It's in the physical exam. And it just doesn't say extremities normal. It doesn't say extremities in the review of systems normal. And then they have their own assessment and plan, right? So if you want to bill it on time, it has to be for a legitimate, reason, because any counseling that you do is covered under the preventative physical exam. So in GYN, if you have enough for a separately identifiable problem and you document that, it would be best to bill on the complexity and not on the time, because a lot of time that you might do during a CPE includes things that you found during the CPE. So I would say no. And then also remember, and your billing people will probably nod their head like a bobblehead doll. If you do a sick visit with a well visit, they're going to call their insurance and say, why did I get a bill? And the insurance is going to say, well, your doctor billed it wrong. Call them back and ask them to change it. Sometimes the doctors don't know that that's happening. In some groups, you have one doctor who won't do an E&M with a CPE and another doctor who will. And chances are they either go to the same church, they go to the same bingo game, or God forbid, they're sisters. And they're going to talk about you behind your back. Now, if that doesn't bother you, that's fine. But most people just say an E&M with a CPE is part of doing business. And I wouldn't do it if you're just going over medicine. You really want to document there's a new problem that you haven't addressed in the past. I have multiple medical conditions. I'm okay. I'm alive. But when I go to see my internist or my family physician, now it's a family physician, I get my free Obamacare physical, and by God, that's what I want. And even though he's going to refill my medication, ask me how I'm doing, cost of doing business for this guy, it's not worth him doing the CPE. So I'm sorry I rambled on about that, but bringing it up, I had to really kind of talk about that. We were receiving denials for E&M codes with a diagnosis of contraceptive counseling. Our patient wants STD counseling because she's a new parent. Should we? Yeah, there are 9940 codes that are preventative in nature. And again, you have to know that some insurance companies pay for those and some don't. So if we wanted to look at 99406, oops, sorry, 99, oh, I have my numbers down, 99406. Oh, come on, stop it. No, I'm going to start over again, apparently. You'd want to go to your Medicaid fee schedule and your Medicare fee schedule to make sure those are covered. Because if you're a doctor, of course, your Medicare patient shouldn't be asking, even though Medicare covers the STD screening. So what am I doing? Okay, 2022, we want, this one, we're going to say that we're in Georgia 99. Then I have to go over here and just double check. But I do think that's right. I think it's a 994 code. Now watch what I'm doing here. Stop texting me. Give me a second to do this one thing. You guys have turned this into Stump the Chump Hour. So here's your preventative counseling, 99411. That's in a group. That's in a group. Alcohol, substance abuse, alcohol. So I must be missing it. I'm way off here. Where's my back button? Oh, here we go. Yeah, here we go. 99401, 1530. Okay, so if I go here and I type in 99401, 99402, 99403, 99406, 99407. And I'm just going to see if there's an allowable amount here. Okay, so you can see here CMS doesn't cover that. So then if I go to the Medicaid fee schedule, and I just typed in Georgia Medicaid fee schedule, or no, better yet, I'll just go MMIS Georgia Medicaid, and go to the portal, and I go to fee schedules under the heading provider information. You notice I didn't even have to log in for this. Physician fee schedule PDF. It's actually kind of good that you asked this question because there are some other nerd things that I can show you here. So here's all your allowables, and I'm going to scroll down to the 99 codes. This will save me maybe going over a very complex issue with prolonged service. I might cut that down a little bit since we're doing this. All right. Now, look here on the Medicaid fee schedule, too. It tells you 26 and TC. These codes cannot be counted. Anything with a TC or a 26. Because you're getting separate. You're already being reimbursed for that, right? So then we get down here. We're getting closer. I know I could have done Control F. Don't think about that. I didn't think about that. I'm just doing everything the hard way today. Oh my God, how many of these are there? So if I go to 994, oops, I probably don't know if I got to the 99. We're in medicine section now. Oh God, there's so many codes. How do I know all these? One thing I always like to point out is that Medicaid does cover physicals on people. It's on their fee schedule, they cover it. They do not cover 401, 402, 403, and 444. So you see it's missing. They do cover the tobacco counseling. Now, we talked about the 99406. Yeah, that's it. They still pay for consult codes, which is, I think, is really weird. Yeah. So they still pay for outpatient consult, and inpatient consults. And Blue Cross doesn't even pay for those anymore. There's your ER codes. Woo! Go to the emergency room with a simple problem. It's $17 is what you're going to get paid. This is why a lot of people, GYNs have to take Medicaid. You don't have to, and some don't, but, typically GYNs have to take this. And the reimbursement rates are just terrible. Look at that. That's less than a Medicare 213. It's just crazy. So I hope that answered your question. I don't know why you have to have two separate notes for previous exam. Yeah, Lakeisha, if you're going to do this split billing, what they call it, for a preventative and an E&M, technically you don't need two notes. If you have enough information that sticks out in the preventative, I'm a big fan of two notes, but I'm very conservative. So I would say, yes, you can do two notes. You should do two notes. The AAPC says two notes. The AHIMA says two notes. So you do your physical, and then you just would, at the bottom of that note, say, patient also complained of a new problem today here. That's the way I teach people to do it. But then technically, there's, that's just based on our society. But technically, you can do it in one note, but you just have to make sure that the history addresses that problem, the review of systems addresses that problem, the exam addresses that problem, and your assessment and plan addresses that problem. I want to check one more thing here on the GOG. Let's see, ICD-10. Oh, yeah, Z30, are you using that? Oh, yeah, you do. What's Z3009? If you were a private client of mine, I would have you send me the denials, because sometimes we miss stuff, Now that is a 4-character code, but your commercial insurance companies might want you to do something different. So I would Google Blue Cross and Blue Shield. Let's see if I can even find it here. Blue Cross Blue Shield contraceptive coverage. I've never had this question before. And they don't even really address it. Look at this one in Minnesota, because most of them follow the same one. Is that it? Well, annual exams. They don't really address it even in that policy. So anyway, that's kind of a weird one. Yeah, they don't even really talk about that. Huh, interesting. Well, that might be why you're not getting paid. I'd also want to look at, again, to finish that sentence, if you're not getting paid for it, nobody has ever asked me about this. If you look at the denial reason, that would tell you why it's being, and I know you've looked at it, but look, I'm going to offer some things to certain people, but I'm going to say to you, let's see, I'm going to say to you, Debbie, if you write down my fax number at the end of this, next week or so, I'll take a look at it and see what I can find out. 10819 to be precise. I don't know what that is, Nicole. So I think that's a CPT code. It's 5 characters. 10819. Nope, I don't know what that is. I don't know what that is. Nicole, you might have to tell me what that is. All right, Tammy, let's see. Patient came in for an annual Results came back for abnormal pap. Nurse schedules for colposcopy during that visit and be counseled on HP prevention and Gardasil. We have been charging for both procedure note and an office visit. Some are being denied. Again, anytime you mess around with somebody's preventative benefits, it just, I know what you're doing is kind of like makes sense, but so many commercials now are saying, we're only going to pay you for the preventative and you can't do anything else. You have to identify who those folks are. And then unfortunately, if you want to bill for that, sometimes you have to bring them back for a separate encounter. And I know that that's terrible for the patients, but there's been a policy floated around CMS, which everybody will default to, that says, if you do a preventative with an E&M, we're going to cut the E&M by 50%. You know, like United Healthcare already does that. So the general rule of thumb is if you do anything with a preventative, chances are the patient's either going to get angry or there's going to be a denial. I'm sorry. Okay, so if it's a separate visit, if you do the counseling on the day of the procedure, anything related to the procedure is bundled into the procedure because that would be a minor surgical procedure. And again, the minor surgical procedure is defined as everything that you do on that day that resulted in you doing a procedure is covered under the procedure. So that's the minor surgery and major surgery rule. With major surgery, you get an exception to that because your decision for surgery can be done the day before or the day of surgery, but not with minor. So you'd also have to look, I mean, I'm just telling you from a compliance standpoint that typically that's the problem. And you don't necessarily in the CPT book need two different diagnosis codes. You can use the same diagnosis, but again, the insurance companies don't always follow the CPT rules. So if you were appealing those, I would probably go to my CPT book and copy that section out of my CPT book. So since you asked, let me just show you. And wait, I know where that's at. That's in my. Thanks for everybody being patient. But if somebody has this question, you know, I know as the coding nerd what the rules are, but the insurance companies again don't always follow those. Right, so here's my Kindle. Thanks for being patient with me here. It'll give me a second to take a drink of coffee. You can see I buy my CPT books off Amazon, which infuriates my wife. She hates Amazon. She hates everything. So funny. And if I go back to Appendix A in your CPT book has all your modifiers. And we go to 25 right here. Now, this is going to be in your CPT book. I don't know how to make that larger. It may be necessary to indicate on the day a procedure was done, a CPT performed and the patient's condition requires separately identifiable E&M service above and beyond other services or the usual pre- and post-operative care. So some insurance companies are like, if you bill a procedure with an E&M, we're going to deny it. So when I had to get this seborrheic keratosis, my dermatologist examined me. She was able to bill an E&M with that because it was the first time she saw that problem. But if I go back to get liquid nitrogen again, or this problem has already been addressed, and in your case, it was scheduled by the nurse for the patient to come in, those are the kind of services that are going to be bundled. What would be the better coding tool between codifying and Encoder? All right, it's a great question. Codifying and Encoder Pro. Encoder Pro is and I saw it yesterday. I live across the street from all the rich people. I saw the 2022 Bentley pull into their gated community, and I was so excited. I'm like, oh my God. And my wife goes, you're nuts. And I go, to me, that's Ed Sheeran. I mean, you love Ed Sheeran. You may be watching, you know, My Chemical Romance came out with a new song yesterday, so we had to watch that. Everybody was giddy, but to me, a Bentley is great. I've actually asked for my birthday, which is May 31st, for my wife to get me. If you like Friends, there was an episode where Joey got a bunch of Porsche stuff, like a hat, jacket, keychain. And I said, just Bentley me for Christmas. I'll wear it everywhere. But Encoder Pro is a Bentley, right? Now, I can still get to Publix in the car that I use, I don't have a car because I travel and I just go rent a car. Like tomorrow, I pick up a rental car for the next couple weeks. So I have in my driveway, what is it, a 2002 PT Cruiser. Now, it's the junk car we bought for my son when he was in high school, and he's 30 years old. Then it was handed down to my daughter when she was in high school, and the thing runs like a dream, and it's only got about 100,000 miles on it. So my wife says, you don't need a new car. So short story is, I can still get to Publix in that beater 2002 PT Cruiser. Codify is the 2002 PT Cruiser. It does almost everything that Encoder Pro does, but it's nowhere near the price. So what I tell people to do is, if you go to encoderpro.com, they offer you a 2-week trial. You can check it out, and the same thing with Codify, but Codify is expensive. But with this one software program, I get everything I need. So watch this. Let's go with something that I see a lot of, 20610. So that's a common code for large joint arthrocentesis, right? So I pulled it up. I can say where I'm at. It gives me all of the global payments. So see here, this doesn't have a 26 or TC, but I don't know if I'd count that as a procedure or a test. I wouldn't. Over here, it has all the codes that I can, all the modifiers I can use with it. It has all the ICD-10 codes that cover most of this service, and there are 522 ICD-10 codes. And what does it also do for you that was helpful? Normally, if you click on the local coverage determination, it'll have a policy. I'll use Florida. It's an old Native American word for fraud, Florida. So this is vasosupplemental. It'll take me right to the policy if I want to look at it. And again, Codify does all that, but it's just not as sexy. Besides, they give this to me for free because they know I'm going to use it in presentations. You can get your medically unlikely edits. That means you can do 2 of these per day. And that's what is nice about this. It's easy for me to use. They have free education and training. But again, Codify is a great program. I just don't need to use it. And, oh, look, it gives you the global days. So this would be considered a minor surgery. And if it showed up on your report, which it wouldn't because you're GYNs, your doctor would say, oh, yeah, 20610 is considered a minor surgery unless the patient is on a blood thinner, unless they're diabetic. There you go. Those are the kind of things that it does. And Codify, again, does, I think, pretty much the same thing. I just like this. This is all of the knowledge that I used to do manually in one software program, and that's why I like it. All right, let's see. Let me get back here. What time is it? Oh, good. We got 15 minutes. Okay, so let me get through this presentation real quick. The one thing I was going to talk about the most, doctors all the time are asking me, hey, Steve, how can I bill for prolonged services without the patient present, right? Now, these 2 that I circled in purple are prolonged. Oh, no, they're not. Nope, we're in the wrong one. Now I'm all nervous that I'm not going to get through. These 2 codes are non-face-to-face prolonged services. So let's say you saw a patient on Monday, you ordered all the labs, tests, everything else, right? And it comes back on Wednesday, and you literally spend, close to an hour going over all this patient's information. Now, they're not there, and it's not the same day as total day care. You can look at 99358 and 99359. Now, those codes require you to document a start and stop time. And it also needs to result in an upcoming E&M visit. So in other words, I work with a bunch of doctors in Maryland, not a bunch, there's 2 of them, that specialize in Whipple procedures, which is a pancreatic cancer surgery. Now, before they consider you as a candidate, they have to get all your previous medical information. This is going somewhere, so stay with me. They go through all the data, they document the time, and if they allow the patient to have surgery, that's going to result in an encounter with them. They can bill for all that pre-time. If they go through all the information and decide they're not a candidate and they're not going to see him face-to-face at some point in time, they can't bill that time. So prolonged service has to result in another E&M face-to-face encounter. All right. Again, you know, it's first hour. This is one of those codes where you can go 1 minute past the midpoint and use it. Medicare has a policy in their manual, 104 Chapter 12, where they refer you to a prolonged service time chart. And they kind of still, even though they say you don't have to go the full, we would expect that you would only bill this code if you do a full hour. So CMS is kind of not following the AMA book. So I would, you know, if I'm doing Medicare, I'd probably go the full hour. And if it was commercial, I'd go 31 minutes. Now, these codes are the prolonged on the same day, right? Total daytime on the same day. I'll forget about all these since we're running late. You know, you would never use those anyway. So just write down on a piece of paper, look at 99, and don't believe me, Google it. Go to the GOGS, and you'll be able to find tons of articles. Go to cms.gov, manuals, 100-04, Chapter 12. And if I have time, I'll show you how to do that. Right. So I think I have an example of that. Okay, yeah, I do. So here's some time examples, right? It's in a whole other seminar that I do, but I have already created the templates. Now, if you want to do prolonged service for a new patient, you have to go 89 total minutes because it's 74 plus 15. And for a 215, you'd have to go 69 minutes because that's 15. If they have Medicare, it could be it's the G2212, and if they have any other insurances, it's the 99417. But don't worry, Medicaid doesn't cover this, and which is ridiculous that they don't cover this code. But your commercials do. But wait a minute, Steve, the CPT book says you only have to go 1 minute. So that would be 75. Yeah, sure. Go to my website and read the policy from Anthem. And they lump their 99417 in with the G2212. So they expect you to go the full 15 minutes. Again, the AMA book, if you open up the AMA CPT book, there's not one certified coder that's part of the editing process. It's physicians. And, you know, we have some really good editorial panel members in the GAFP that I know well, and there might be somebody in the Georgia OBGYN Society, but, you know, a lot of times every year he's so super, he'll send me an email and say, hey, Steve, we're getting ready to meet. What problems are you finding? What are you seeing that I can bring to the meeting? And then after the meeting, he'll send me an email and says, what does this mean? What are you doing here? And so it's always fun. But just remember, the AMA book doesn't always jive with any carrier manuals. So here's a 215. Remember, just the 215 by itself, I talked about documenting the total time, being exact, don't use a range. And I listed at least 4 issues that the doctor did here. So, yeah, educating him on weight loss. Yeah, I've lost 40 pounds since COVID. So, yeah, I decided to turn COVID into something positive. I went back to school, picked up a second degree, an associate's degree in general studies because I wanted to just learn. I wasn't traveling. I was bored at home, not being on the road. And I liked that so much that I transferred to another college to pick up another bachelor's degree. It's just stupid. Here's the G2212. Time is so important. You know, I live in 15-minute increments. Yeah, I had to go back and change all these to Mrs. Adams. So again, 69 minutes is for a 215. You'd have to go 89 minutes for a 99417 or a G2212. Here's prolonged before and or after. I just told you about 358 and 359. And here's an example of that. This will give me a second to drink a sip of coffee. It's an 85-year-old new patient, multiple complicated medical problems. She moves to Augusta to be closer to her family. And my wife's best friend is moving to Seattle, and they're taking their mother-in-law with them. She's brought to a new physician's office by her daughter. The doctor indicated the past medical records would be obtained, right? So a week later, the records come in, and the doctor spends 45 minutes reviewing the old records, labs, office procedure notes, and the patient's not there. It says not the same day, and you would document this as like the date of service, start time and stop time. Total time was 45 minutes. During this time, I reviewed the patient's information obtained from Dr. Apostle, my old family physician. I reviewed the old records labs. So you're doing this because the insurance companies that do pay this, let me show you the reimbursement rates. No problem, Renee. I just saw your message there. And go to Encoder Pro again. And again, I'll just type in 99358. And there's the code. And when I go down here, that pays $110. So that's somewhere at the bottom end for Medicare of a 214. Let me see what a 214 plays. I've been telling you it's 120. Let's see what that new rate is. I'm sorry. I get to chasing rabbits. Oh my gosh, yeah. So 214 in Georgia pays $122.16 and the 99358. Now I would always tell you too to be, this isn't a code you should use 5 times a day, but there are examples, and this pays in your office $106. It has the same reimbursement as the facility fee. Now, did I keep? Just to show you the bad thing here. So let's go to the MMISGA Medicaid. So again, you can do this as fast as I do it. Go to the portal. I'm going to go to fee schedules. I'm going to download it here. And I probably already have it on my laptop somewhere. And let's go to see if they do 99358. You'll be stupefied that they don't, right? If they don't. So 99345. Yeah, they don't pay for it. So why would they, right? Okay, you get the idea there. I'll leave the fee schedule up in case we come across something else that's important. So every time you have a question about something, just check both fee schedules. Last thing, I think I'll be okay. Yeah. Telemedicine is so important for us to take advantage of. There's audio only and there's audio and video. Unless it's Georgia Medicaid, they'll let you bill E&Ms if you have a patient who doesn't have video the state kind of takes into account, and I know this is a terrible thing to say, but almost everybody has an iPhone, and but the assumption is there are going to be some Medicaid patients that don't, right? So if you're sitting out there thinking, really, I have Medicaid patients who pull up in a Mercedes, and have Rolexes. I don't delve into that. I'm just telling you that Medicaid assumes that most people on Medicaid, because you have to be below the poverty level, which is I think about $19,000 a year now, you're not going to have audio video. You can't go to your internet website. And so 5 to 10, 11. The good thing about these codes is if you use them, these pay the same as a 212, a 213, and a 214. Okay? They're really good codes to use. What can you use them for, though? A lot of doctors don't know, right? So on the Medicare telehealth service list, which is what the insurance companies typically follow, there's a link here in your presentation. But if you just go to if you go to Medicare telemedicine coverage, you'll find this same link. So here it is. Oh, it's coming up in Google or Chrome, which I don't use. Telehealth. See, I'm going to click on this. It is a list that I have screen capped in my computer, but I need to show you how to use it. What I want to let you know is that during COVID, my private clients still saw patients. They still billed, and they didn't get impacted as much as people who didn't know this website existed. Now, this column D says audio only, right? If there's nothing in this box, that means it has to be audio video, okay? So, if we go down to some of the codes we talked about today, okay, so E&M codes have to be audio video for most insurance companies. That's why I threw that out there. Just like hospital visits have to be audio video. So I look at the yeses. Okay, well, we're not doing psychiatric, but, we might do tobacco counseling. So if you had audio video, then you did a 203 and you documented you spent, 4 minutes doing tobacco counseling and used the right diagnosis, you could bill this too. Now, the reason that I highlighted this is because I want to show you that because there's a guest there, you can do it audio. And, if we go down here and just look at annual well visits, those can be done over the phone. Depression can be done over the phone. Intense behavioral therapy for cardiovascular can be done over the phone. You can do critical consults are in there, but they have to be done audio video. Here's that prolonged E&M code. Again, that has to be 69 minutes for an established, 89 for the. But I had private clients who would bill, GO439, 99497, 99406, GO442, GO446. And they would just come in, and it was really kind of cool. The young people who work at the front desk know everything about it. I still don't know how to FaceTime on Facebook Live. I don't know how to do any of this stuff, right? So I can't even use my Apple Wallet. If I did, it would be by accident. So my wife puts our concert tickets in there, our NASCAR tickets in there, our, all of our shows. I don't even know how to shut my phone up. So when it rings, I freak out. Those are some of the things that you did. So they'd have the young people who understood how to do that. They would call their patients, explain to them how to do audio video. Because most older Americans had, they had a Facebook page for their grandkids. And then the nurse would just FaceTime them or call them. So the nurse practitioners, the PAs, the docs were still coming into their office, but they were just billing stuff over the phone. So just kind of be cognizant of that. This isn't my list, but if you'd like, I will save it. And I will also put it in the list of stuff that I send to the OBGYN. So again, and that is the telehealth thing. So let me save it real quick for you. File. And it's in Excel, and I'm not your IT guy. So if you don't know how to use Excel or it doesn't open up because you don't have Excel, I can't help you. Desktop, I guess I could save it as a PDF. Let me see what it looks like as a PDF. All right, it'll pop up here in a second. Nah, it's not gonna. I don't like that. So I'll send it to you as an Excel. Most everybody should have Excel in their office. Okay. Scroll that. You all have access to the fee schedule, to GAMUS. You're going to probably do codified, but you can try that. That's your CPT book. That's your fee schedule. And I'll save this here. File, save as, browse. I'll put it on my desktop. Okay. Oh, and this is just to show you that I'm not lying about Al Pacino. My face trying to. Oh, God, I don't know what I'm doing. So I'll send you that. The thing with the phone calls is this is my last, should be about my last slide here because I've only got a couple minutes. You want to document if it's audio only, you have to do consent, topics, and the exact amount of time, right? If you're doing a 99441, 442, or 443. If you're doing audio video, you want to document that it's audio video, that you have consent, and the topics, right? So audio video, it's a medically necessary history, medically necessary exam, and complexity in the note. Or you can do audio video on total daytime as well. So even the time after you hang up the audio video, you can count that time. But the thing most people miss is the consent. They don't put in the time. It's just terrible. So make a template for those if you don't work in a large hospitalization. Okay. So other than getting sidetracked a little bit, which I think was really educational for me, we talked about the performance measures. I gave you the number to call. We talked about the two sections with the removal of the biodegradable stuff and then the deletion. That was the major change. We talked about the ICD-10 update. And I think the big thing there was the low back pain and that code for non-suicidal injury. Preventative meds, I talked about the visual acuity, the health risk assessment. We talked about the shared visits in the hospital, not in your office. So please don't go back and tell your doctor, we can't do incident 2 in the office anymore. That's not true. You still can. You still can for Medicare. Most commercials, though, want you to bill under the person who provided the service. So they will credential now NPs, PAs, and MDs, or PAs and CNMs. If you work at a large facility, though, you need to check with your credentialing people, because a lot of times you don't have to do that under your contract with the hospital. They just require the SA modifier. We talked about what was not Peace for Mom, but you watched the 10-minute video that I found was really, especially in today's world, WIC is a wonderful program. When I was in the Army and we had our first child, I was all on WIC, man. I could not get enough cheese, peanut butter, formula, milk, and getting it for free. It didn't bother me because I'm like, hey, I work for the government. I work for your country, and they're not even paying me enough to buy cheese. So I probably shouldn't have had a kid, but it was right before I got out of the Army. I wanted the government to pay for my delivery, my wife's delivery. We talked about the 214 reminders, chronic, at goal, chronic, not at goal, blah, blah, blah. Talked about social determinants of health. Billing on time, I talked about total daytime, how many minutes you need, and I talked about prolonged services without the patient present, and I told you that Medicaid doesn't pay for that, nor do they pay for the 99417. And then we talked about telemedicine and telehealth, and the big thing there is the consent. Okay? So, I've already answered all the questions, I think. Also, will telehealth go away? Yeah. Okay, do you mind? So, Lakeisha asked me, will telehealth go away after the public health emergency? 2 years ago, I would have said yes, but I think that so many patients are kind of used to that now. My psychiatrist is in Fort Lauderdale, and I communicate with him. I have Blue Cross Blue Shield, and they're still covering that for free. I like telehealth for certain services. So I don't know if President Biden will rescind that. I think a lot of people enjoy it. A lot of people like it. So my gut tells me that they won't. But if they do, then you just can't bill it unless you're in a healthcare professional shortage area, and there's a remote site where there's a doctor who has credentials. So, it's still up in the air. But right now, my heart of hearts, I can't see the president stopping that. So if you needed to email me something, there's my email. I do a lot of chart reviews, workshops, seminars. I teach a coding course. Where's my next coding course? Oh, it's next week in Albany, Georgia. I'm doing a CPC coding course over 3 days to kind of get you ready for the Certified Professional Coder exam. And that's it. That's actually it. So let me get out of all these presentations. Close that. Close that. And this is just the proof that this is my screensaver. I just love Al Pacino. All right. Let's see. I'm going to send that email after I convert this bad boy, which usually takes me about 3 hours. And info backed up. Sure, yeah. You'd almost think that I'm not trying to pick up additional work. There it is. So there's my contact. For hospital visit is a specific number of diagnoses and data. Yeah. I mean, for hospital visits, you can still use up to 12. You can still use, let me see, for hospital visits, is there a specific number of diagnoses or data points? Oh, okay. So this is kind of a bizarre question. When it comes to the hospital visits, we're still using the 95 data. So, of course, there are, if you go back to the old days, that's how you would do it. So like independent reviews counts as moderate, but they don't count up individual lab tests or individual x-rays. You get 1 point for all the blood work that you order. You get 1 point for no matter how many x-rays you order. You get 1 point for reviewing labs or x-rays. You get 2 points if you independently review an imaging, tracing, or specimen. But you have to go back to the 1995 rules. And let's see if you have that already. It looks a little bit like this. So I don't know if you have this coding talk. Here's my handout for that. So if, I do a lot of hospitalist work now. Now the good news for hospitalists is Medicare is going to use the codes and stuff, the rules that I just talked about, they're going to use those for hospital E&Ms next year. Okay. So if I can make this a little bit bigger. So these are your, this will look familiar to you because they took a lot of this information and incorporated that into the 97 guidelines. Oh, no, and I don't do the OBGYN certification course. But those are really fun. The AAPC has knocked out 50 questions from every certification exam except the billing one, I think. And they give you 4 hours. So, and they normally have pretty good stuff. And right now, I think they're running a sale. So, the presenting problems, diagnosis, and management, same thing in the E&M world. You still need 2 or 3. But this is your data set here. So your data points, if you've got a camera, you can take a snap of this. This is how you do, so all the x-rays that you order would be 1 point. All the labs that you ordered or review would be 1 point. All the stuff in the medicine section, echoes, cardiography would be in there. Discussing the test results with the performing physician, now that's category 3, and it supports a level 4 category on its own, but you only get 1 point for that now. And for certain diagnosis codes, you need a certain number of points. So independent review is still worth 2, and decision to obtain all records is 1. And the way the system works is typically you need moderate here, says 3 points. That would be your 99232. And you go down here and you need 3 points from here or 3 points from here. So if it's an established problem that you've already addressed in the H&P and it's worsening, that's 2 points. If you're reviewing all the blood work and tests and stuff, but there's a simpler way to do it, and this is what Medicare uses. So all that gibbly-goop really means nothing. What CMS follows is this rule here. And it's a very simple rule. If you got your camera, you can take a stop at it. We bill the 3 1s if the patient's doing fine. If they're responding to your care and you're not ordering anything new, we give it 2 3 1. 2 3 2s are patients that aren't responding adequately. Maybe you're ordering additional labs. Maybe you're ordering additional medications. And then 3 3s, the patient's completely unstable or has developed a significant new problem. The best way to do hospital visits is this way, but you also have the ability to bill them on time, right? So a 232 would be 25 minutes of unit floor time. I did the following. So I spent 25 minutes on the floor, greater than 50% of that was spent doing this, that, and the other. So that's another way, even if the patient's responding well, which is down here, we can still bill based on time. And a lot of people use time for a 99233. So you get to have a patient that's responding well, and you're ready to discharge them, but it took you 35 minutes on the floor to make that determination. So even if they're responding well, time, just like on the outpatient codes, usurps decision making. So that's kind of how hospital codes work. So I hope that helped you. All right. Wow, we're 8 minutes over. You're cutting into my lunchtime. Like so many of you, I have a schedule in front of me today. So this is supposed to be 9 to 12, and 12 to 12:30 is my lunch, and then reviewing a couple interventional cath reports. It's no fun. I don't normally work on Fridays, and now I have to work all day. I know, whatever. So there you go. I always enjoy doing this talks for the Georgia Society of OBGYN. I do a lot of stuff outside of this, so feel free to call me or contact me. The folks who I told that they could fax me something, I don't expect faxes from 400 people. And also, please, I'm booked up for months, and I'd love your questions, but I have a tendency to not answer questions from people who don't pay me. And you're the same way. If I went to your doctor, of course I wouldn't but if I sent my wife to your doctor and she just expected a free annual exam, you'd be like, no way. And I'm the same way. So, kind of be cognizant of that. If you have a simple question, like I know Tammy Reynolds sends me some simple questions every once in a while, and I appreciate that. If you're typing more than 3 lines, though, what's that saying? Too long to read, TLDR. I might just respond that way and say, this is too long. Because I have people sending me 5 pages of notes and they want me to code operative reports. And I'm like, no, dude, I'm busy all day with people who pay me. So, but if you want me to come out to your office and help you out, I can. So anyway, God bless you all. Thank you so much for your 3 hours today. Now, Nicole will be sending out your CEU certificates. If you watch the recording and you weren't here on this one, technically you are not allowed to use those 3.0 CEUs because I don't have this registered as an audio video conference. Okay. So keep that in mind. Your CEUs will come from her. Your CMEs will come from her. I don't remember if this is approved for Category 1 CME. It might be. I don't remember. But any CEUs or CMEs will come from ACOG, so you don't have to email me about that. Have a great day. God bless y'all. Thank you for your comments and your questions.